single theme meeting will start with the state of art lecture on nutritional management in liver ICU, challenges and solutions. To chair the session, I would like to invite Dr. Sunil Dadi sir. He is professor and head at SNMC Jodhpur, and Dr. Karan Kumar, assistant professor hepatology at Mahatma Gandhi.
Hello. One again. Hello. Hello. Good morning, everyone. After the brainstorming session yesterday on sarcopenia, its mechanism, its pathophysiology, and then clinical implications, then the myths and how to assess and treat the sarcopenia in liver disease. And today we are starting with a first lecture from Dr. Puneet Puri. He is from Virginia Commonwealth University. Something about Dr. Puri. Dr. Puneet Puri is a graduate of SMSC Medical College, Jaipur. He did his MD under Dr. Kunal Kothari and also Dr. Rupai and Dr. Nijaman. And then he was trained at the University of Mass and then NAS Fellowship at Virginia Commonwealth University, where he is working right now. And he has made some seminal contributions in the field of obesity, metabolic and alcohol-associated fatty liver, with focus on microbiomes and metabolomics. He oversees nutrition and intestinal failure program with special interest in clinical nutrition and models of care in liver disease. Dr. Puneet will be presenting his lecture virtually. Can I request to start his lecture?
I would like to extend a heartfelt thanks to Professor Saraswat and Professor Dajij for the invitation to speak on a topic very dear to my heart, nutrition and liver ICU challenges and solutions. I have no disclosures. What kind of patients do we typically see in an ICU setting that have liver disease or underlying liver problem? Generally, those that have presented with an acute insult, either in the setting of an acute, no known prior liver disease leading to an acute liver failure, or those that have known chronic liver disease, either non-cirrhotic or with cirrhosis. They could either be compensated or decompensated. This acute insult could come from a variety of sources, as shown here, including viral infection, autoimmune etiology, alcohol abuse, and drug-induced liver disease or injury, among others. As a result of this acute insult, there are downstream effects, including organ failure, both liver and extrahepatic, such as the lung, heart, brain, or kidney, and the coagulation abnormalities or failure. A specific entity that has caught a lot of attention and merits specific mention is an acute and chronic liver failure, which the three different societies, the Asian Pacific, the European, and the North American, have all agreed to many common facets. However, there still remain certain controversies that relate first to the type of acute insult, which could be either hepatic or extrahepatic. There are that controversial points. Underlying liver disease, which is presence of cirrhosis or non-cirrhosis chronic liver disease. And lastly, the concomitant extrahepatic organ failure in the definition of ACLF between a fossil versus the other two societies. Therefore, different severity criteria and prognostic scores have been proposed and validated. These are summarized in this particular facet, where EASL and NAXL both take cirrhosis into account, while apostle is chronic liver disease or compensated cirrhosis. Of note, multiple organ failures are part of both EASL and the NEXL definition, while apostle is largely related to hepatic injury, and as a result, their scores are developed based on hepatic failure, while the ACLF score and grading are developed with multi-organ involvement in other two things. Common to them is the rate of mortality. As the disease severity progresses, like grade 1 to grade 2 to grade 3, in all three classifications, there is a significant high mortality, anywhere about 3/4 to nearly about 90% people ending up dying in short span of time, generally a 30-day mortality, which is a very ominous sign. So before we go into the specifics of the nutrition, I would just like to bring attention to nutrition physiology in critical illness, regarded as the very first process is an acute injury that brings in catabolism. And this acute injury is further assessed in an acute phase, both early and late periods, which acute phase early period is day 1 to 2 usually, which also has associated suppression of autophagy. In addition, the acute phase could extend into late period from day 3 to 7, and subsequently a late phase from day 8 onwards. The outcome of acute injury could either continue to progress and persist as prolonged inflammatory and catabolic state, or there could be recovery and rehabilitation, which is associated together with anabolism. Our goal with nutrition interventions are to try to promote the recovery and rehabilitation through anabolism and diminish or attenuate the inflammatory and catabolic state. So what happens during the acute phase and early period, which is day 1 and 2 of critical illness? Predominantly a catabolic state that also generates energy. Catabolism also will continue to occur independent of exogenous nutrition support. This is associated together with suppressed autophagy, which is a physiologic response to fasting that promotes cellular regeneration. So as a result, on the first 2 days of acute phase early period critical illness, there are two processes: catabolism with production of generating additional energy, as well as the suppression of autophagy that promotes cellular regeneration. In face of that, if full nutrition support is provided, it is generally going to lead to overfeeding and could be detrimental. Therefore, it is generally not recommended to provide the full nutritional support in the early day 1 to 2 phase. You can start with enteral nutrition as soon as possible and within 24 to 48 hours, and only up to 40% or 50% of patients' estimated caloric needs should be provided during this phase. During acute phase but late period extending from day 3 to 7 in acute critical illness, it's a transitional period. Ideally, recovery will begin with waning of catabolism as shown in the figure earlier. Also, nutritional administration can be ramped up during this period, trying to get closer to the goal estimated needs. More importantly, the late phase of day 8 plus in acute critical illness is a main transition into anabolic state. It also promotes regeneration of lost muscle tissue. However, some patients may remain in a state of persistent catabolism as if, like the original insult, cannot be resolved. Important that full nutrition support should generally be provided at this point, which includes both sufficient calories to balance out all caloric expenditure as well as protein needs. So what are the challenges that we face in light of acute critical illness or liver ICU patients? First of all, there are very limited data specifically on patients in liver ICU setting. And part of it is that majority of ICU settings throughout the world have medical ICU where patients are predominantly non-liver related conditions. So that limits our ability to generate high quality prospective randomized controlled trials in this specific population. Other challenges include how to accurately assess their nutritional assessment, those who are at risk and those who are malnourished. Moreover, nutrient needs and delivery, specifically in terms of energy or calories, protein, carbohydrates, are also challenging. And in what are our goals and how to approach a specific population, which is obesity, because a lot of patients, almost a third of population currently, have obesity in general, and more so with the growing burden of natality, there is a larger proportion of obese patients that we encounter in liver ICU setting. The conceptual model for nutritional risk assessment in the critically ill come from two phases. One is chronic starvation as a result of their chronic advanced progressive disease in most patients, as well as an acute insult associated with acute starvation. Together, there are organ failure and disease severity based on SOFA and Apache scores, as well as the age. That's an important determinant in contributing to nutritional status and at risk. Together, there is acute as well as chronic inflammation. All these intersections affect nutritional status, as well as they deplete body's immune function and lean body mass, affecting significant clinical outcomes, including mortality. So what are our tools that we can leverage to assess those who are at risk for nutrition or malnutrition? For hospitalized setting, a tool that may be relevant is the Royal Free Hospital and Nutrition Prioritizing Tool. And this is more specific with patient population of alcoholic hepatitis or tube feeders. And there are several advantages that it's simple, practical, and specific to cirrhosis population. It has excellent intra-observer and inter-observer reproducibility, as well as good external validity. It is also predictive of clinical deterioration and transplant-free survival. However, there are small disadvantages that it is validated only in cirrhotic and cannot be extended to non-cirrhotic population, which is not of interest in this particular talk. Also, impact of nutritional therapy based on screening score are not well established. So here is just the flow that if patient is known to have alcoholic hepatitis or alcohol-associated hepatitis, they get a score 6, which directly puts them into high risk category, which is very important. There are other variables like BMI, fluid overload status, unintentional weight loss, dietary intake preceding week or months, as well as the acuity of their illness and in the change in body weight over the last 3 to 6 months. And based on these scores, there are score 0 is low risk, score 1 is moderate risk, anything between 2 to 7 is considered high risk. Also, the Royal Free College also developed and validated a global method for assessing nutritional status in patients with cirrhosis. And through that, they were able to identify who is adequately nourished, moderately malnourished, or suspected of being moderately malnourished, or severely malnourished. The two main criteria were the body mass index greater than 20 or so, or less than 20, and then the mid-arm muscle circumference greater than 5th percentile or less than 5th percentile in both situations. Together with those, the dietary intake, whether adequate or inadequate to negligible, qualified them whether they fell into the moderate malnourished, severely malnourished, or adequately nourished category. There are other approaches and tools that are at our disposition for measuring muscle mass or sarcopenia and the various body composition. However, they are not as clinically applicable or very validated in acute critical setting. And these are listed here just for the completeness sake. There's another important nutritional risk assessment tool, which is called Nutric and Modified Nutric. And this is, again, specific to this particular talk may be valuable because it is in critically ill setting. Of note, majority of the components listed in this or that are included in Nutric or MNutric score are not directly related to nutritional status, however, are taking into account the disease severity and acuity as well. And this has been externally validated in over thousands of patients. The disadvantage is that one of its integral component is interleukin 6, but in modified Nutric score that is modified and taken out. It does require some training, and then, as I mentioned, the classic nutrition parameters are not considered in this score. What the score comprises of age, aperture 2, SOFA, number of comorbidities, days from hospital to ICU admission, and interleukin 6, and these categorical scores combined together provide two categories. When interleukin 6 is available, the score 6 and above is high risk nutrition or high nutrition nutric risk score. Less than 5 or 5 is low risk nutrition nutric risk score. When there is no IL-6, then 5 and above is considered high nutric risk score, and less than 5 is considered low nutric risk score. The concept is that those with high nutric risk score have worse clinical outcome, both mortality and length of ventilation, as well as these patients are most likely to benefit from aggressive nutrition therapy is the proposed hypothesis. So there are very limited data, and we pioneered this study that just did not include the risk stratification, but also the impact of nutritional intervention in patients based from MNutric score. In this particular study, over 150 alcoholic cirrhotic patients were studied in critical care. The nutritional requirements were based on ideal body weight, because this enrollment period was in 2017 at the time, based on the Aspen guidelines. Energy trends were 35 to 40 kilocalories per kilogram of ideal body weight, and protein 1.2 to 1.5 gram per kilogram of ideal body weight. Protein intake was subsequently increased in select subset of patient population to 1.8 to 2 gram per kilogram in case of those that are obese or those that require renal replacement therapy. Notably, those that with higher nutric risk score were older than the low nutric risk score. Also, the predominant etiology difference was the high nutric risk score was predominantly alcohol-related cirrhosis, and as expected, their SOFA and Apache scores were significantly higher compared to the low nutric risk score. Also, here is a breakdown. The high nutric risk score, the mean scores were 5.9, and compared to the low nutric risk score of 3.8. When we assess the nutritional adequacy of the critically ill patients with chronic liver disease during ICU stay, in both categories, high nutric and low nutric score had comparable caloric adequacy as seen here. No significant difference in their caloric delivery or protein delivery were noted. Very important that the nutritional status at time of admission increases overall mortality in critically ill patients with cirrhosis, and this is nearly threefold higher odds of death in patients that have high nutric risk score. So certainly it gives a very strong predictive value, as well as targeting a population that is at higher need or immediate need with nutritional support. Prioritizing this, the effect of nutritional status at ICU admission also impacts other outcomes, including infection onset, as well as duration for mechanical ventilation, which was nearly double in those that had high nutric risk score and nearly 10 to 12-fold higher risk of new onset infection in those with high nutric risk. Both very ominous signs and can lead to a high mortality in the subset of patient population. Very important observations in our cohort was that if you look at this, the high nutric risk score is in the maroon bar, and the blue bar is the low nutric risk score. As caloric adequacy improves, greater to 80% to 100% or slightly higher based on ideal body weight, there was significant improvement in their survival, which is shown on the y-axis, and the x-axis reflects the caloric adequacy. Very important. Improving caloric delivery is important in predicting or reversing or improving the outcome. Similarly, the survival was directly correlated with adequacy of protein delivery. Shown again on the x-axis is the adequacy of protein delivery, and then y-axis is probability of survival. The red bar is again the red line where the confidence interval reflects high Nutri-Score score population. And as can be seen here, that with improved protein adequacy in these patients, the probability of survival doubled in this patient population. So that takes us to the next step. How do we assess what is an adequate caloric need and requirement? Currently, there are numerous predictive equations that are utilized. However, they only estimate energy expenditure. And of note, none of them work well, specifically in liver population. The most common approach relies in critical care setting to estimate caloric requirement and an acceptable 25 kilocalories per kilogram per day as a generic broad umbrella caloric need. Unfortunately, estimation is often inaccurate, more so in liver population with a variety of other modifying factors, and potentially could lead to either underfeeding or overfeeding, both of which are detrimental. We also have to be aware of our cognitive biases, meaning by that obese patients are rarely viewed as malnourished by clinicians. However, frequently they do have protein calorie malnutrition and muscle wasting, especially when they have underlying chronic liver disease or advanced liver disease and have an acute insult and presenting with both acute and chronic starvation physiology in addition to inflammatory milieu. So how can we enhance our ability to assess or accurately measure caloric need? Can direct measurement of metabolic rate be of help? More accurate approach certainly seems promising in personalizing nutritional prescriptions. However, there are limited investigations to support tailored nutritional prescriptions based on individual energy expenditure that improve hard ICU outcomes. Tailored nutritional prescriptions may often be of value, especially in situations where predictive equations are more unpredictable, such as extremes of weight, either profound cachexia or supermorbid obesity, pregnancy, or hypermetabolic conditions like burn, thyroid storm, and in this patient situation, severe alcoholic hepatitis, acute liver failure. All of those that may have multiple amputations. How can we measure metabolic rate? While the most accurate approach so far is called indirect calorimetry, that directly measures both the CO2 generation as well as oxygen consumption. This is recommended by recent ESPN, the European guidelines in 2019. Unfortunately, it requires an expensive gadget called the metabolic cart, and which is available only in about 2% of ICU patients. An alternative is a volumetric capnography, which is supposedly simple and is generally available in some of the ventilators, I think, from German make. So this approach requires estimating the respiratory quotient or RQ to be 0.85. The amount of error that is introduced with this approximation is within acceptable limits. And based on that, an estimated daily caloric requirement can be calculated by measuring the VCO2 ml per minute times 8.2. So once we have estimated, how do we initiate the enteral nutrition support? Because majority of these patients are unable to eat by mouth themselves. So current recommendations are that during acute early phase, which are ICU days 1 to 2, target should be up to 50% of usual caloric goals. That may translate about 12.5 kilocalories per kilogram. Acute but late phase, which is ICU days 3 to 7, the target would be about 50 to 70 to 80% of the estimated energy target, or about 80 to 100% of measured energy requirements. In recovery phase, target is estimated to be close to 25 kilocalories per kilogram or measured energy requirement. Regardless of whether we are giving them hypocaloric or full caloric needs, there should be full protein supplementation, close to about 1.2 gram per kilogram per day. So just the general common statement regarding protein requirement, it is often regarding the most important macronutrient in critical illness. It promotes both immune function and maintains the lean body mass beyond other beneficial effects. Most recent trial effort, multi-center randomized control trial, demonstrated that a protein target of 1.2 grams per kilogram per day yielded equivalent or superior results compared to 2.2 gram, which is considered high protein supplementation. Among the subgroup of patients with acute kidney injury, there was also a signal for possible increased mortality when providing higher protein needs of 2.2 gram, although it was not significant, but only a trend. The authors, I'll be presenting more data from that in subsequent slides, also recommended that 1.2 grams per day or kilogram per day is a reasonable protein prescription in patients with critically ill and ICU setting liver disease. What about carbohydrate administration? So after the decision is made that what is the total estimated caloric need and the protein needs, the remaining calories are divided between carbohydrates and fats. Total amount of caloric administration, about 25 kilocalories, and protein administration this. So we have already identified those. Then the remaining calories are coming from fat and carbohydrate. The target for carbohydrate is at least 150 grams in critical setting, which is about 600 kilocalories per day of carbohydrate. This is to help prevent starvation ketoacidosis. There could also be implications of excess carbohydrate. If administered in beyond 300 grams, it may promote hyperglycemia and increase in the insulin requirements, which could have downstream risk of hypoglycemia in situations which is commonly seen in critically ill liver patients, that tube feeds are stopped or interrupted for a variety of reasons, and the patient is still exposed to exogenous insulin. Reducing the amount of administered carbohydrate can certainly decrease hyperglycemia and glucose variability across, and which has been shown that this is across several clinical trials. There's a subset of patients that may have problematic hyperglycemia, example of brittle diabetes, providing only about 33% of calories in carbohydrate form can be reasonable to avoid excessive glucose variability. How to decrease the carbohydrate administration? One approach could be to use supplemental fat, mainly in form of medium chain triglycerides. The main advantage is that these MCTs are compatible with tube feeding formulation and can be used with patients including like other organ failures such as renal, etc. MCT oil provides supplemental fat calories. About 15 ml, which is 1 tablespoon, contains 115 calories. So adding 6 to 8 tablespoons of MCT oil daily can provide additional 7 to 900 calories. And MCT oil is easily absorbed compared to other forms of fats, and it also limits gastrointestinal side effects such as diarrhea. Now, another important component not to ignore and pay more attention to is hypoglycemia. So this study from Switzerland demonstrated that hypoglycemia is associated with increased mortality in patients with acute decompensated liver cirrhosis. When we see the traditional risk factors, the odds of somebody dying as a result of their hepatic complications like ascites or hepatorenal hypoglycemia had higher odds even than hepatorenal syndrome, which is very important to know. It also showed that those that had hypoglycemia had significantly more deaths in the hospital compared to both hyperglycemic and normoglycemic acutely decompensated cirrhotic patients. In survival analysis also revealed that the hypoglycemic patients had worse survival compared to either normoglycemic or hypoglycemic patients. So how can we address hypoglycemia in liver ICU? We very well know that there is depletion in hepatic glycogen stores or impaired gluconeogenesis, as well as hyperinsulinemia. All of these can contribute to hypoglycemia in patients with liver failure or in liver ICU. One can consider continuous infusion of 5% dextrose, but there is always concern for volume overload in this particular patient population. So more frequent glucose checks with goal-directed glucose therapy may be beneficial. In more severe cases of hypoglycemia, the boluses of 20 to 50% dextrose may be used in concentrated form. Hypoglycemia, as stated before, is an ominous sign in patients with decompensated cirrhosis, and a 30-day mortality, as shown before, may be as high as nearly 30%. So 1/3 of patients may end up dying within 30 days if they have challenges with hypoglycemia. So we need to pay attention and address this early in the game. So how do we prescribe nutrition in patients with liver ICU critically ill? So one of the simple tools is this website called EnteralTube from clinicalcalc.com that can be easily utilized and develop a tube feeding prescription. You enter certain patient parameters and such as gender, height, weight, and fluid restrictions, if any, and if they are on any additional agents like propofol, and their medicate the formulation for the nutrition supplement like Jevity, and then goals for kilocalories, total protein goals, feeding duration, continuous or intermittent, and then the protein packets, and then hit calculate. This will generate your full prescription. So it's a simple tool that can be leveraged by either the providers while waiting for the detailed dietary consult and intervention plan. Specific to obesity, the energy provision in ICU can be either categorized based on their BMI, 30 to 50, using actual body weight. Then there's low calorie, 11 to 14 kilocalories per kilogram. Or when their BMI is beyond 50, then ideal body weight can be used with a little higher calorie, 22 to 25 kilocalories per kilogram. The European Society for Parental and Nutrition recommends that patients with obesity in ideal body weight may underestimate energy expenditure. Therefore, they suggest adding 25% of difference between adjusted body weight minus ideal body weight and add that to the ideal body weight, and that should be the caloric needs they recommend. Why it is important? Muscle in critical illness. There's a significant muscle wasting in critical illness, about 25 to 50% muscle wasting, which is half of the body muscle gone. Average daily loss of muscle mass is at a rate of 2 to 3% within first 10 days. And this muscle wasting further correlates with severity of organ failure. Even with single organ failure, there's no significant additional loss. But with 2 to 3 organ failure, the average loss is close to 20%. And with 4 or more organs, it's 25% average loss within 10 days. Such a profound catabolic condition. These changes can also be seen with myofibril necrosis on muscle biopsy. So how could we change this catabolic state into an anabolic state? And it's just a simplistic overview of how protein or through amino acids can shift this status. So generally, the protein breakdown leading to essential amino acids to protein synthesis and catabolism suggests that there is a 30% shift towards catabolism, and for synthesis, it is a 30% depletion. So amino acid exogenous supplementation of 40% can provide an additional impetus for promoting protein synthesis and overcoming the catabolic state and translating it into an anabolic state. It's quite easily said and simplified. However, that's not as straightforward. So the protein needs in obese ICU patient, per the European Society guidelines, it should be guided by urinary nitrogen losses. And it is difficult to quantify that. And it will also require an accurate 24-hour recording of nutritional intake and urine collection. The lean body mass assessment, there are a variety of tools available, but maybe in the given setting when the patients are in critical condition and in ICU, a lot of these may not be easily available. However, some may be routinely performed for other purposes like CT scan, MRI, or ultrasound can be done at bedside. DEXA is generally not that easy. Bioelectrical impedance is there, but its validation in critical care setting still, because of fluid shifts and other conditions, can affect accuracy. If these tools are unavailable, the Aspen guidelines suggest that the progressive delivery of 1.3 gram per kilogram of protein per day based on adjusted body weight is recommended. What does the American Society and the Society for Critical Care Medicine suggest? And there are newer guidelines now, 2022, that has not changed this recommendation. So BMI 30 to 40, 2 gram protein per kilogram of ideal body weight. If BMI is greater than 40, then 2.5 up to 2.5 gram per kilogram ideal body weight. Patients with obesity, they suggest fewer calories, however, important to have high protein diet. That is an expert consensus only. And they state that if available, an enteral formula with low caloric density and a reduced non-protein calorie to nitrogen ratio be used in adult obese ICU patient. So that brings to the next point: how do we evaluate the non-protein calorie to nitrogen ratio in day-to-day practice? This is calculating the 1 gram of nitrogen equals to 6.25 grams of protein. So calculate the grams of nitrogen supplied per day based on the amount of protein that it is going to cause. Similarly, the non-protein kilocalories, and then divide that non-protein kilocalories by grams of nitrogen. And then you get the ratios. So 80 to 1 is the most severely stressed patient. That's the ratio you would want. So you would want less of the non-protein calories and more of the protein calories, which will give you a lower ratio. A higher ratio of 150 to 1 is generally suitable for unstressed patients. Majority of the liver patients fall into the severely stressed or the most severely stressed patient population. And so therefore, these are desirable interventions to be used. So the last part of this talk focuses on the most recent trial, just came out a month and a half ago, called the EFFORT protein trial, which is evaluating the effect of higher protein dosing in critically ill patients with high nutritional risk. It's an international, multi-center, pragmatic, registry-based randomized trial. It was performed in 85 ICUs across 16 countries. Patients chosen were nutritionally high-risk adults over 18 years and undergoing mechanical ventilation. High-dose protein was classified as 2.2 gram or greater per kilogram per day versus usual protein of 1.2 or less kilogram per day. And this was chosen because the recommended Aspen, or the Society for Critical Care Medicine, recommendations were 1.2 to 2 grams of protein per kilogram per day. So they wanted to do high protein, higher than the recommended upper limit, and usual dose protein lower than or equal to the lower range of recommended protein needs. This intervention must be started within 96 hours of ICU admission and continued up to 28 days or death or transition to oral feeding. The primary efficacy outcome was time to discharge alive from hospital up to 60 days after ICU admission. And the secondary outcome was 60-day mortality. Of about over 4,000 patients that were screened, 1,300 plus were randomly assigned, and about 650 were in high protein arm and about 650 were in the usual protein dose arm. This shows the protein delivery in the running first to 2-3 days reached the two different categories: high protein with open box plots and the usual protein dose with the red-filled box plots. And you can see that their range was around 1.2 or below, while the other one was closer to 2.2 or higher. Of note, energy received within the first 12 days of randomization was comparable. So that allowed that high dose versus usual dose protein can be independently assessed, independent of the energy variation. Very important that there was no significant difference in the primary outcome of time to discharge alive from hospital. As you see, the one with high dose protein is blue, and that with the usual dose protein is red. Very similar, no difference. So the key take-home points from effort trial comparing high versus usual protein in ICU was that there is no difference in time to discharge alive even after adjusting for sites and covariates. They also did not notice any, the 60-day mortality rates were also comparable. They also cautioned using high protein specifically in patients with acute kidney injury and high SOFI score indicating multiple organ failure. The subgroup analysis showed favorable trend for usual protein dose that was 1.2 or less grams per kilogram per day in these specific subgroup population of acute kidney injury and multiple organ failure. How could you recognize that they have been overfed or high protein? One of the clues is excluding GI bleed if there is rising BUN levels. Another key take-home point was that prescribing 1.2 gram per kilogram per day, which is the lower end of the ASPEN 2022 guidelines, or 1.3 gram, which is consistent with the ASPEN, the European guidelines, and striving to achieve close to 80% of the delivery seems to be a reasonable and safe approach for all critically ill patients. Higher doses of protein to critically ill patients did not improve either the time to discharge alive from hospital or 60-day mortality. It might have worsened outcomes, although the trend was there but not significant, that those patients with acute kidney injury or greater severity of illness, their outcomes could have been worse. So in summary, how do we assess this whole problem? First, we need to screen for malnutrition. Those that have child class C or BMI under 18, they are as such a high risk category. Other screening tools that we talked about, the RFH or the Royal Free Hospital Nutrition Prioritizing Tool or Nutri for NNT score. Detailed assessment, including dietary intake, sarcopenia where possible, subjective global assessment, as I also showed from Royal Free Score Hospital, as well as the acute and idle body weight measurements. There are some special situations. I did not touch upon this, but these are worthy of attention. So plant-based proteins to have possible role of branching amino acid in encephalopathy specific population. Also, if there are avoid low calorie delivery, those that got over 21.5 kilocalories per kilogram per day fared significantly better compared to those that received less calorie. Also, early enteral nutrition should be attempted even in those with GI bleed and or after liver transplant. Some general principles we talked about. This is possibly in a slightly higher range, but depends what calories are based on idle body weight or some other measure. Protein intake is appropriate, small frequent meals, late evening snack, especially in the pre-admission phase. Enteral mode is preferred, and don't forget the other vitamin and mineral supplementation that are part of this critical illness, like zinc and others. So recapitulating acute phase, day 1 to 2 or day 1 to 7, that divides into early and late period, and then the late phase. So again, in acute phase, the target is to gradually escalate the caloric needs and try to maintain the from 50 to 75% within the first 3 to 5 days, and then gradually reach the 100% target for caloric needs. In addition, protein needs should be tried to be met at target close to 1.2 gram per kilogram per day in both acute and maintenance phases. Post-ICU phases, recovery, rehabilitation, similar post-hospital discharge if patients can make it back. So some summary points regarding nutrition in liver patients in ICU. One big question comes when to initiate or how much to feed. And the recommendations, again, in summary, are low quality and conditional, but general agreement is to initiate early, preferably within 24 to 48 hours of ICU admission. Never delay an initiation in nutrition while waiting for an official nutrition consult the next day. As I shared, the calculator can easily be used to quickly determine an initial tube feeding regimen. Gradually escalate nutrition support in early and late periods of acute phase, reaching about a 75 to 80% goal, and then into the late phase to reach full goal. Gastric residual volume should not be checked routinely, and follow electrolytes closely, including magnesium, phosphorus, especially when initiating nutrition. And if phosphate starts falling, consider refeeding syndrome and accordingly manage. For patients that develop refractory hyperglycemia, consider changing their enteral nutrition formulation before resorting to large doses of insulin. In conclusion, ACLF is also a specific condition which has spectrum of severity. No one shoe will fit all, so one has to make clinical judgment and use best guidance possible. Early recognition with nutrition risk assessment and early intervention can improve short-term survival. And these may have a potential to serve as a bridge to a transplant. Also, it would help to have a consensus on ACLF that can potential to improve and enhance outcomes. Of course, large studies are needed to guide an evidence-based manner. Thank you for your attention. Good morning, everyone. First of all, I would like to extend a heartfelt thanks to Professor Saraswat and Professor Dajij for the invitation to speak on a topic very dear to my heart.
Thank you, sir, for airing the session. Now we move on to our second session on the state of art lecture. To chair the session, we have Dr. Ajay Duseja, Professor and Head of Hepatology, PGI Chandigarh, Dr. Harsh Udawat, Senior Gastroenterologist, SDM Hospital, Jaipur, Dr. Sakeet Agrawal, Senior Gastroenterologist, Jeevan Rekha Hospital, Jaipur, Dr. Ashok Jhajaria, Associate Professor, Gastroenterology, SMS Hospital, Jaipur, Dr. Naveen Kumar, Consultant Gastroenterologist, RHL Hospital, Jaipur.
So, good morning, everyone. So, moving on to the session 2, which is on the management of sarcopenia and obesity in cirrhosis. And to start the session, may I request Professor Anup Saraya, who's Chief of Gastroenterology and Human Nutrition at AIMS New Delhi, to speak to us on challenges of sarcopenic obesity. So,
So at the outset, I would like to thank the organizing committee for giving me this opportunity to be here. And when Dr. Saraswat told me to speak on this topic, I never realized that there are challenges and challenges only in this field. There is no consensus of anything as far as sarcopenic obesity is concerned. So this was first described in 1996 as reduced lean body mass with increased fat mass on BIA, and mainly described in elderly population. So this whole thing was actually described in elderly population because now longevity is increasing and so is obesity. So there are two epidemics now, and because of that there is this problem of sarcopenic obesity. The morbidity and mortality due to sarcopenic obesity is higher than risk related to either obesity or sarcopenia alone, and British Regional Heart Study has shown that in more than 4,000 patients they studied, that the mortality risk was 55% higher in subjects with both sarcopenia and obesity compared to either alone. So ESPN and European Association on study on sarcopenia, they recognize and indicated sarcopenic obesity as a scientific and clinical priority, and complication rate of sarcopenia and liver cirrhosis, as we know, is fairly high. And what we have observed that the muscle loss, rate of muscle loss in child A, B, and C cirrhosis is 1.3%, 3.5%, and 6.1% per annum, which is much higher than the rate of 1% of muscle loss in general elderly population. So there are gaps in knowledge and challenges. Diagnostic challenge. Most of the data is interpolated from elder population. In fact, there is hardly any data specifically from various disease group. These studies are carried out in aged people. Definition and criteria is not uniform. There are many studies and their cutoffs are different. Their diagnostic criteria is different. Modality is different. So there is no uniformity and marked heterogeneity in various studies. Underlying pathophysiology is not completely understood, and there are different drivers in old age and in younger age. That is also not known till date. Consequences of sarcopenia are worse than those of sarcopenia alone or obesity alone. There is no concrete evidence to draw any firm conclusion till date. Although there are studies, I'll go through that also during this lecture. And long-term consequences on endpoints like cardiovascular disease and mortality are also largely unknown. I am talking of sarcopenic obesity in elderly also, and there are hardly few studies in patients with liver disease. So what are the age-related changes which we encounter? Increase in fat mass, which peaks around 60 to 75 years, decrease in peripheral subcutaneous fat, preferential accumulation of visceral fat, ectopic fat infiltrate in muscle and other organ, increase intramyocellular lipid. This is one phenomena which is seen in obesity. Skeletal muscle mass and muscle strength is also decreased, and rate of decrease in muscle mass after 50 to 60 is fairly high. Mostly this is type 2 fiber which is lost, and they switch to slow type 1 fibers. What are the hormonal changes which are related with aging? Increase insulin resistance. This is in the center of everything. Decreased thyroid hormone, decreased level of insulin like growth factor, sex hormone, and growth hormone, and there is also increased cortisol level. These are responsible for mechanism of muscle loss as well as obesity. The prominent manifestation of sarcopenic obesity is insulin resistance and anabolic resistance. So insulin resistance and anabolic resistance will lead to loss of muscle mass and increase fat in the body. So if we really want to standardize the things, then what is needed? As we see that there's marked heterogeneity, we should have something by which we can measure the body composition. Then cutoffs should be very clearly defined, and then there should be agreement in various modalities also to some extent. Then these are the methods by which we assess sarcopenia and obesity. I will not comment much on sarcopenia. It's been discussed the whole day yesterday. So as far as obesity is concerned, for obesity, we use BMI, waist circumference, DEXA, anthropometry, and BIA. And to confirm that, we can use MRI or CT. Then what are the criteria which are generally used these days? BMI more than 30 in Asian population, more than 25 kg per meter square, and a percentage of fat mass, which we assess by various methods, 28% in men and 40%, 35, more than 35 to 40% in women. That is taken as criteria for obesity. And central obesity, we say then waist circumference is more than 102 centimeter in men and 88 centimeter in women. In Asian population, a circumference of more than 90 in men and more than 80 in women. These are cutoffs for sarcopenia. I'll skip. And this is again severity sarcopenia. I can skip, and assessment also. So then, as far as sarcopenic obesity is concerned, ESPN and European Society, they formed a group and they analyzed around 75 articles. On the basis of that, they defined obesity, as I have already told you in the previous slide, and their approach to diagnose. For that, three things are important: how to screen, how to diagnose, and how to stage. So for screening, they have recommended that we should look for BMI and waist circumference and surrogate markers of sarcopenia. If both conditions are applicable, then we should go for diagnosis. And they have also emphasized, although there is no consensus on many points, but they have reached to a consensus that it is the muscle function which is most important. And so, in the second step in the diagnosis, what they say that altered skeletal muscle function parameters should be considered, like hand grip strength and chair stand test. If that is positive, then we should proceed further and assess various other functions and muscle mass as well. When both altered body composition and altered skeletal muscle function parameters both are altered, then we should make a diagnosis of sarcopenic obesity. So this is the consensus till 2022. And then we stage the disease. If there are complications associated with sarcopenic obesity, we say stage 1. And if there are no complications, stage 1. And if there are other complications like metabolic disease, functional disability, cardiovascular risk, or respiratory disease, we say that it is stage 2. So, as far as screening procedure is concerned, it should be accessible, affordable, easy to use tool. And BMI, as we know, is an easily accessible, acceptable tool. Implementation of a screening procedure is a must. And then waist circumference can also give us an idea. So this is how on CT scan we can make out the deposition of fat in the subcutaneous tissue, in the visceral tissue, and even in the muscles. These are various studies in which the prevalence of sarcopenic obesity is around 2 to 42% in patients with chronic liver disease. And there is one term, obesity paradox. When prevalence of obesity in adults has doubled since 1980, and obesity we know can accelerate the progression of liver cirrhosis status and progression of NAFLD. So we know this fact, but what is obesity paradox is a phenomenon in which obese people are found to have a reduced risk of death compared to people with a standard weight. Somehow this phenomena is difficult to explain, and most studies on obesity paradox use BMI as an indicator of obesity. But obesity is essentially a condition associated with increased adipose tissue mass, and it is difficult to accurately assess adipose tissue mass with BMI. There are cases of excess visceral fat even when BMI is within the normal range, and attention should also be paid to amount of visceral fat in cases with sarcopenia. The protective effect of obesity primarily is caused by malnutrition and weight loss management in patients with CLD. So these are the studies in which they have shown that although they were having sarcopenic obesity or sarcopenia, but still the chances of various complications were less. Now coming to what is the mechanism of sarcopenic obesity? So what happens in aging? There is unhealthy diet, lack of exercise, change in body composition, change in hormonal status, and there may be multiple chronic diseases. This can lead to inflammation, oxidative stress, and insulin resistance, and then how sarcopenia, as far as sarcopenia is concerned, we know there is muscle atrophy, lipid infiltration or lipotoxicity, GLUT4 or resistance, that is insulin resistance, anabolic resistance, and then the satellite cells are also less. There are certain satellite cells, these are like stem cells, and they can differentiate into adipocyte also. So inside the cell also, in between the muscles, you will find at times adipocytes. In obesity, what happens? There is um, more adipose tissue, and then there may be inflammation. So, adipose tissue, there may be inflammation, there may be infiltration by the inflammatory cells, and this low grade inflammation may lead to insulin resistance. Same thing may happen at the level of muscle also. And then in muscle, because lipid is more and it cannot be disposed of, so it will be disposed of, and there is also insulin resistance. So this fat will be utilized through beta oxidation, and when that is impaired, it will lead to mitochondrial dysfunction and generation of oxidative stress. So that will also lead to more adiposity, and this can there is unbalanced metabolic homeostasis and ectopic fat deposition. When fat is there in excess, it will spill over to other systems as well. And so, when there is inflammation and inflammatory cells are released, or inflammatory cells are releasing these cytokines and myokines also, this will affect liver ultimately, and there also there may be insulin resistance and more lipolysis and fat deposition in the liver, leading to NAFLD and progression of that disease. This is how I have, in this pictorial diagram, I have tried to give you an idea how sarcopenia, obesity ultimately lead to liver dysfunction. And once liver is involved, what will happen? From the muscle, certain myokines are released, and one is myostatin. This myostatin, role of myostatin is well known in cirrhosis and in liver disease. So I will not go into the details of that. This is how the whole thing start. There is expansion of adipose tissue inflammation and dysfunction, increased fatty acid production. When exceed the oxidation capacity of skeletal muscle, there is deposition of fat in the muscle, and effect of function of GLUT4 transporter lead to decreased utilization and beta oxidation in mitochondria, leading to free radical generation, impaired sensitivity in skeletal muscle, intracellular fat deposition, increased TNF alpha, leptin, and decreased adiponectin. This adiponectin actually has a positive impact on insulin resistance. So once adiponectin is less, this will affect liver as well, because receptors are there in the liver cells also. This is how the fat is deposited and lead to ultimately liver involvement. And myostatosis is common with sarcopenic obesity. This is present within the muscle fibers and can be measured by CT, MRI, or muscle biopsy. CT correlates well with MRS, and it's a negative prognostic factor in cancer, in emerging factor in cirrhosis. 50% of patients evaluated for transplant had myostatosis and associated with increased risk of hepatic encephalopathy. This I have already explained. So now coming to the impact of sarcopenic obesity in various outcomes. Both sarcopenia and obesity are risk factor for fibrosis progression in NAFLD, and patients with sarcopenic obesity have a higher prevalence of significant fibrosis and cirrhosis than those without. So twofold higher risk of having NAFLD associated significant fibrosis with coexisting sarcopenic obesity. And in SCC, sarcopenia and obesity are established risk factor, and retrospective study of 465 Japanese patients having preoperative sarcopenic obesity more than doubles the risk of death and SCC recurrence after hepatectomy. There is cognitive impairment also. Presence of obesity is related to mild global cognitive impairment even at an early stage. with executive function and information processing speed being affected the most. Obese patients, they have a lower brain volume. These studies are also there. And on histopathology, there are findings specific of Alzheimer's disease that has been reported in experimental model of obesity. Sarcopenia is more potent predictor of cognitive function loss than obesity. And since sarcopenic obesity is associated to insulin resistance, this mechanism may contribute to cognitive alteration observed in these patients. There may be osteosarcopenic obesity. This is also a known fact that loss of mechanical impact of muscle on bone and positive effect of insulin on bone tissue is gone. So there may be osteoporosis or osteopathy. And it has been seen that patients with, especially with visceral fat, present a significant greater risk of fracture, inflammation, and poor metabolic profile. Now, sarcopenia correlates with chronic diseases, and it increases mortality due to all cause dependent on criteria used, greater gait limitation than those with only one factor, and sarcopenic obesity precedes disability to perform instrumental activity of daily living, limiting quality of life. It is associated to poor quality of life according to HRQOL questionnaire compared to obesity alone. Then, as far as metabolic disorders are concerned, the highest risk of insulin resistance, metabolic syndrome, dyslipidemia, and vitamin D deficiency has been seen, and higher 10-year CVD risk than the non-sarcopenic, non-obese group. In contrast, risk of CVD was not high in group with sarcopenia or obesity alone, and increased risk of type 2 diabetes. Comorbidities are also more. Now, coming to impact of sarcopenia and cirrhosis, the median survival with sarcopenia was 22 plus minus 3 versus 95 plus minus 2 in controls. And you can make out that the patient with sarcopenic obesity has a shorter survival. So there are challenges in therapeutics, no specific drug therapy for sarcopenia available, and there is a need for myostatin agonist, antioxidants, or mTOR activator. Safety of efficacy of approved drug for obesity needs to be tested. Then use of skeletal muscle mass alone versus strength or performance, which modality to choose from, cutoffs are valid across all disease groups. All these are challenges and unanswered questions. In identifying obesity, important to use ethnic specific cutoffs. BMI is inaccurate for body composition. BMI is inaccurate for identifying those with isolated visceral adiposity, and it is inaccurate in presence of increasing extracellular water like ascites and edema. Abdominal CT, DEXA, and BIA are more accurate marker of body composition, but had limited availability. So in summary, what are the challenges? The challenge, diagnostic criteria for sarcopenic obesity need to be redefined. Implication of sarcopenic obesity in addition to sarcopenia and obesity alone need to be outlined. The obesity paradox need to be clarified, and studies evaluating exercise and nutritional intervention in patients with cirrhosis and sarcopenic obesity need to be done. And studies evaluating pharmacological intervention in patients with cirrhosis and sarcopenic obesity need to be done. Thank you.
Thank you, sir, for an excellent talk. We'll take questions in the end. Next talk is by Dr. Ajay Duseja on management of obesity in liver cirrhosis. Dr. Duseja is professor and head of Department of Hepatology, PGI, Chandigarh, and his keen interests are NASH, hepatitis C, and HCC, and he has more than 500 publications in national and international journals. Dr. Duseja, please.
Sure. Good morning, everyone. And at the outset, again, my sincere thanks to Professor Saraswat, Professor Dadij, Dr. Karan, and the other members of the organizing committee for organizing this meeting and giving me this opportunity. I think we've been hearing since yesterday that both sarcopenia and now the obesity, they are all risk factors and maybe independent risk factors for the poor outcome in patients with cirrhosis, and these outcomes poor outcomes are related to the increased risk of decompensation, the peri-transplant mortality, and the post-transplant mortality. So these are, some of the earliest studies which had shown that, obesity is a risk factor for decompensation and poor outcome. But then slowly and slowly now we have realized, and in the previous talk you heard, that the sarcopenia and obesity, can obviously coexist in a patient and becomes more challenging, managing both. On one hand, you want the patient to lose weight because he is obese, but on the other hand, you don't want to compromise on the nutrition because that's so very important in cirrhotics, which we have been hearing, since yesterday. So when you talk about, management of obesity in cirrhosis, uh, it's as I said, there are two things. One hand, you want them to lose weight, but on the other hand, as I said, they are sarcopenic. You don't want to, kind of compromise on their nutrition, especially the protein intake. Uh, Obese people could also have associated comorbidities, and these could be, diabetes, hypertension, dyslipidemia, coronary artery disease. So they also need to be taken into account when you are managing an obese cirrhotic. And you also probably have to look at the etiology of cirrhosis and then managing these complications. So, the holistic approach obviously is required when you're managing an obese cirrhotic. But then what I'll do is I'll just be covering, sarcopenia we have been hearing since yesterday, the management and I'll not be covering about, the management of the various associated comorbidities, and also not be touching upon the etiology and the complication of cirrhosis. So my job for next 10-12 minutes is to basically tell you how can we help these patients, reduce their body weight, and on the other hand, as I said, maintaining a good nutrition in them. That's the thing I'll cover in maybe next 10-12 minutes. So when it comes to, weight reduction in any obese, and this applies to even obese cirrhotics also, we have in our armamentarium, we have four things. One is the lifestyle interventions, which means your diet and exercise. Pharmacotherapy, there are some certain weight loss, medications which are available. Just show you some data whether these can be, given to obese cirrhotics. Then now you have, new modalities, especially the endoscopic modalities which are coming in. And these are in short called as EBMT, or endoscopic bariatric and metabolic therapy, which help in not only weight reduction, but also in controlling various other metabolic issues, including diabetes. Then finally, you have, the surgical management, which is the bariatric surgery. So I'll just, as I said, in the next 10 minutes, I'll just show you whether these things which are routinely done in obese people, can these be applied to an obese cirrhotic. So that is the, thing which we need to do. So now coming with the first, I'll just tell you what the guidelines in journals say. Somebody, there's an obese cirrhotic, how much is the weight reduction? How should you do the weight reduction on? So let's start with the lifestyle interventions. So lifestyle interventions, if you look at the European guidelines and our Indian guidelines, which is the INASL guidelines, and mind it, these are applicable only to compensated cirrhotics. We are not discussing here the decompensated cirrhosis. So in general, the weight reduction advised is around 5 to 10% of their baseline body weight. And this is to be done, as I said, by only restricting the calories by maybe 500 to 800 kilocalories per day. But the protein intake has to be adequate, which has to be 1.5 gram per kg, the ideal body weight. So that has to be done. So in addition to the calorie restriction, and as I said, maintaining the protein intake, they need to be advised moderate intensity exercise, which could be a combination of both aerobic and anaerobic exercises. But then again, these need to be tailored according to the patient's ability. These cirrhotics we have been hearing since yesterday are not only sarcopenic, they are also frail. So they may not be able to do the kind of exercise which you would like them to do. So it has to be tailored according to the patient's ability. And as I said, keeping in mind the sarcopenia, and also you heard about the concept of myosteatosis, which is so very common, again in these obese people, and then more common in so-called the NASH cirrhosis. So what is the data on the lifestyle interventions? Again, this is one study which is widely quoted, and this study is known as the sport diet study. So, this study, what they done was they taken 60 patients with compensated cirrhosis, and they all had portal hypertension, which is defined as, HVPG of more than 5. And then the BMI was close to around 26, and a quarter of them had NASH as the etiology. So they were, given this lifestyle intervention program, and as I said, the recommendations are to reduce the calorie intake by 500 to 1,000 kilocalories per day, and the proteins were kept at around 30%. This study was, later criticized as a letter to editor, because the protein intake which they had, suggested was zero point 0.8, which is probably lesser. And these, as I said earlier, I think they need to be given a good protein intake, which has to be around maybe 1.5 gram per kg per body weight. But then they were also advised, 60 minutes per week of the supervised, physical activity. And what they could show in cirrhotics, that there was a reduction in body weight, maybe by 5% in around half of them, and maybe by 10% in around 15%. But in addition, what they showed was that as the weight reduction was happening, there was a reduction in their portal hypertension, which was measured again by HVPG. And those who had, more weight reduction, say maybe 10% or more, there was a greater reduction in HVPG in them. And this weight loss was maintained over a period of time, and there was no clinical decompensation, no worsening of their liver disease as measured by CTP and MELD. So, exercise has to be supervised, calorie restriction has to be there, maintaining a protein intake. I think this is feasible even in cirrhotics. But then the problem is, as I said, they are not able to exercise, so they need to be supervised. So, the people follow what are known as personalized physical exercise programs, and you have to do that, as I said, tailor them as per the need of patients, and as per the ability of these cirrhotics. As I said, they are frail. So I think accordingly, they have to be told about the exercise, and as I said, the calorie restriction and the protein intake has to continue. Now, coming to the second thing, which is the anti-obesity medications. Now, these are the long list of medicines which are approved by FDA for usage in patients with obese. And these drugs, if just to name, orlistat, phentermine, topiramate, combination, naltrexone, and the bupropion combination. And then you have two GLP-1 agonists. One is the liraglutide, and other is the semaglutide. And one drug is in the pipeline, tirzepatide, which is a GIP and a GLP agonist. Now you look at the contraindications here. The liver disease doesn't figure in as the contraindication. So cirrhosis is not a contraindication for use of drug. The problem is we don't have any data about the usage of these drugs in patients with cirrhosis. So that is the problem. So in 2019, when we did the nasal census on nutrition in Chandigarh, and that was later published in 2021, that time this drug was there in the market, and this drug is from a company called Eisai, and this lorcaserin is a serotonin receptor agonist, and then there was one case report that time where they had used this drug in a morbidly obese cirrhotic pre-transplant. But later on in 2020, this drug now has been withdrawn from the market. FDA has requested the company to withdraw this because of the increased risk of malignancy which were observed in the safety trial. So this drug is not available. So what you have now is a drug called semaglutide, which is a GLP-1 agonist, as I said, and there's a phase 2 data where it has been shown to be useful in NASH. There is a phase 3 study which is going on, but this is a very recent study from Rohit Lumba's group where they have used this SEMA 2.4 milligram once weekly in NASH related cirrhosis. So this is the only study where you have an anti-obesity drug, and this drug is approved, as I said, as an anti-obesity drug. So in cirrhotics, this is the first study. In this study, the primary aim was not weight reduction. They were again looking at NASH resolution and improvement in fibrosis, which they did not achieve in this study. But when they looked at the weight reduction, this was much better in the SEMA group. So I'll just take 2 more minutes. So this is a 10-minute bell if I'm right. So the SEMA group, there was larger weight reduction in comparison to the placebo, good glycemic control. Again, you are worried about side effects of these in cirrhotics. So when they looked at the safety profile, overall adverse events were seen in around 70-80% in both placebo and in the SEMA group. But the serious adverse events were not very large. They were just 5-6% and predominantly GI. So which actually gives us the message that this drug is safe in cirrhotics, can induce your weight reduction, may not improve your liver disease. So this is the message from this study, the semaglutide. Now, third modality, which is the endoscopic modality, and as I said, we call it as EBMT or endoscopic bariatric and metabolic therapy. There's a long list of procedures. The time will not permit me to get into all these details. I'll just show you the data which is available in cirrhotics, and the only data which is available in cirrhotics is with the intragastric balloons, which means that you put in a balloon endoscopically, and for the weight reduction. So the first study of this, came from the Medanta group. This was in 2016. Very, small number of patients, 8 patients, whom they were kind of working them up for liver transplant, for living donor liver transplant, and there was a mismatch between the donor and the recipient. What they had, a low graft to recipient waist ratio. So they wanted these recipients to lose weight. So what they did was they put in this intragastric balloon in them, and 5 of them all had weight reduction, and 5 they could even transplant them with the weight reduction. So this was a kind of proof of concept that the balloons can work in patients with cirrhotics. And then you have now the larger studies, and one of the study, again, it's a multi-centric study including various centers, including ILBS. There were 56 cirrhotics now, with a BMI of 35 and a weight reduction close to around 15 kg with balloon. They have seen even reduction in HVPG, portal hypertension, and reduction in their fibrosis score with LSM. And again, these balloons were largely well tolerated. Only one patient had persistent vomiting and no decompensation. So I think the balloons would be. So last is the surgery. Again, surgery, again, if you look at our NAFL guidelines, which we have come up recently, and even the nutrition guidelines, which we came in 2021, the bariatric surgery is a difficult proposition in patients with cirrhosis with a risk of decompensation. So in decompensation, I think you don't do bariatric surgery unless it is done during transplant. So in general, if you look at this large study, which actually showed that if you look at patients without cirrhosis, compensated and decompensated, the kind of mortality which was happening was much higher in the decompensated, 16% versus 0.9 versus 0.3. So, decompensated, no bariatric surgery. In compensated, you can individualize and see if it is no other thing is working. Maybe you can decide with a writer that they would also have a little poorer outcome. And this has now been shown in a larger, systematic review, 18 studies done again by the ILB, All Institute group, and where they had shown that if these cirrhotics, they are put on metabolic bariatric surgery, they have higher complications. But out of these surgeries, in compensated, there are various kinds of bariatric surgery. The sleeve gastrectomy, the LSG, they call laparoscopic sleeve gastrectomy, is probably the safest and probably better than the Ru and Vi. So to summarize, I'm just showing you again 2019 nasal consensus published in 2021. As I said, we have really not gained much in these 2-3 years. And so the in a obese cirrhotic, I think if you have to advise them weight reduction, it will be 5 to 10% of their weight reduction. This has to be done with lifestyle interventions with the reduction of maybe 500 to 800 kilocalories per day reduction, but maintenance of protein intake of maybe around 1.5 gram per kg per day. That has to be done, number one. Exercise has to be tailored according to the patient's ability to do exercise. Moderate kind of exercise, maybe 60 to 70 minutes per week is probably good enough. The no anti-obesity drugs, as I said, there's no lack of data, but semaglutide now looks promising. I think probably we would need more data on this. Out of the endoscopic modalities, maybe balloons can be used in selectively patients if there are no contraindication. Bariatric surgery, big no, and decompensated, yes, and compensated, you can still maybe individualize. And out of the various surgeries, laparoscopic sleeve gastrectomy is probably the preferred surgery and the safest. So I'll also take this opportunity to invite every one of you for the annual meeting of INAZL, which is happening in Bhubaneswar, 3rd to 6th August. So thank you very much for your kind attention.
Thank you, sir. Now we would like to invite Dr. Shalima, who is professor at Department of Gastroenterology, AIMS, New Delhi, and is a keen interest in acute liver failure. He has got around 350 publications in national and international journals. Dr. Shalima, sir, please.
Okay. I hope
He is going to speak on the topic management of sarcopenia in cirrhosis, in whom, when, and how.
So
Dr.
at
Shalima,
the
sir.
outset, I'd like to thank Saraswat sir, Dajit sir, and the organizing committee for inviting me out here. So my task is to talk to you about the management of sarcopenia and cirrhosis. I think we've heard a lot about sarcopenia and cirrhosis over the last one day. So I would try to avoid repetition. So the talk would be on these points. I'll briefly talk about sarcopenia and cirrhosis, talk about its prevalence. My task specifically is to talk to you about management in who, whom, and how. So I'll try to focus on that specific points. So this is a patient who was admitted, who's currently admitted with us in our ward. See, he's got just bones. He's elderly. You heard in the prior talk by Professor Sarayas is talking about as aging happens, you got sarcopenia. Superimpose on it is chronic liver disease. He's decompensated. He's ascites. He has ascites. His age is 80 plus. Can you reverse it? Can you make it better? Are we talking about this to resolve? Let's see what do we have some data and can we do something for this. So whom is the first point which I am going to talk to you about. There are a couple of meta-analyses of sarcopenia in patients with cirrhosis. So the results have varied. Varied in the sense is one, people have used different techniques to evaluate sarcopenia. So you use a different technique, you get different results. You combine together in a meta-analysis, you again get another jumbled up result, and you don't know how to interpret it. So there comes with something like heterogeneity when we talk about. So there's a lot of heterogeneity in the data. So when you interpret this data, just keep that in mind. There is problems with the meta-analysis when you collate apples and oranges together. It's not something like a papaya and mango. To give it a nutshell, every third patient with cirrhosis has sarcopenia. Carry home messages. Every third patient whom you are seeing in OPD has sarcopenia. Let's look at a little bit of intricacies in this data when you analyze into different subgroups. Males have more sarcopenia as females. This is what comes from these meta-analysis, but there are issues with the meta-analysis, and males may be having similar to females. We need more data. We need good quality studies on that. But current data suggests males have more sarcopenia than females. Etiology-wise, alcoholics have more as compared to patients with other liver diseases, specifically evaluated in studies as non-alcoholic fatty liver disease. You heard about sarcopenic obesity also. Liver disease progresses from child A, B to C. There is increased prevalence of sarcopenia. You heard about it. It's associated with poor outcomes. I'm not going to talk about it. So what comes from this data is that every patient whom you're seeing in outpatient or inpatient who's got cirrhosis is at risk. So whom is every patient? You need to talk to every patient of cirrhosis whom you see. You need to assess them, see whether they've got sarcopenia or not, and make a plan. Even if they do not have sarcopenia at that time, with whatever test you've heard since yesterday, which can be used to assess sarcopenia, to talk to your patient about, he may develop in future. You need to educate. You need to start talking. Unfortunately, this part is something which we lack. We lack because we don't have that much amount of time and we are all seeing so many patients. But this part is something which we miss out. Identify the contributing factors. Comorbidities you heard about. Cirrhotics are predisposed to endocrine disorders, they've got bone disorders, they've got heart diseases, they've got other comorbidities associated with portal hypertension. All of these lead to all more problems. So you need to manage all this. And more important is the fact is it's not at baseline assessment. Whenever the patient comes back to you, at every visit, put in some time to see. You heard yesterday Professor Sarin sir telling you is how you can do it at bedside in the outpatient. Unfortunately, I don't do it. I'm sure 95% of us sitting over here will not be doing it apart from part of studies which are going on because you don't have that much amount of time. So these are various tests which are available. You do whatever test you want. Do keep repeating the same test, document it, and see whether it is going up or down. So it's going down, it's a major problem. So when is at the first visit we talking about is even if the patient doesn't have, do assess him, do use whatever tests available to you, start talking to him. You start talking to him about his disease, what he has. Think about talking about optimizing it better, use of specific therapies, which we heard, etiology treatment of portal hypertension should be done. Next comes the important thing of food. We've been eating so much of good food. We had such a good dinner yesterday with lots of alcohol also. So important things, you need to avoid such things in your patients. And you need to have good calories and proteins. You've been hearing about the calories and proteins. Just ensure that you have a good diet chart. I would never talk to my patient about how to make a diet chart. I don't have that much time. And I'm sure most of us would not be doing it. So here comes the role of a dietitian. We had very excellent lectures yesterday. So keep a dietitian as a part of your team. Individual cannot do it. It's a team which does it. So, and then comes this physical activity. We are all saying we heard about is ask a patient to do exercise. You will be talking to patients. Does he go back and do it? You know that patients with NAFLD, even if you do ask them to have a diet, they don't. Nobody follows it, and it's a major problem. People don't even lose 5% of body weight. 95% of patients will not lose even that much amount of weight. So it's really very difficult. It's about this diet and exercise. You tell him not to eat a salt restricted diet. Have you ever tried self eating a diet which doesn't have salt? You won't be able to eat it. So you need to tell them what is a salt restricted diet. At least they need to have some salt, some palatability, and oils is something which we heard yesterday. So you need to make a diet for an individual patient and needs to be tailor made. You need to put in time into that and think about other system involvement, comorbidities, which we heard about. So these all things need to be come in at the first visit. So that's very important. Next comes is at the first visit you've diagnosed. Now what do you do? So you do an early diagnosis. You found out that this patient has. You start looking at the risk factors. Risk factors we've heard about since yesterday. You just look at all those and start trying to do a checklist is have you taken care of all those risk factors? Can you do something extra to take care of those risk factors and help improve this? Build again is a diet and exercise and start looking at treatment. Again, looking at managing all these things, including the etiology, complications, diet part, activity, and other physical systems. Next comes is there's a concept of recompensation coming in. What has happened? Can you reverse it out? So there comes is the role of tertiary management is. So if a patient now has sarcopenia, I showed you an image of an elderly male. Can you reverse him out? That is something where most patients, what you're going to see in your outpatient would be like that. So because patients come always too late and being at tertiary care centers, you'll only see sick patients. So can you reverse that out? Is there a concept of recompensation of sarcopenia, which can be as of decompensation? As we are thinking about recompensation of cirrhosis, can sarcopenia be recompensated? You need to have a good team working on it and think about again the same similar concepts which I have talked about. You've seen this slide multiple times. I would like to just highlight few points over here. Pathogenesis of sarcopenia is not one single mechanism, it's multiple mechanisms. It may be because of the etiologies, you need to take care of that. Inadequate activity and more sedentary lifestyle. Ammonia, we've talked about. Dietary intake, we've talked about. Endotoxins, SIRS, all this thing which we talked about. Testosterone. This is something which I'm going to talk about because nobody has talked about. Rest, everything has been talked about in multiple sessions. I'll not put in so much of time on it. This all leads to sarcopenia. So what has been proposed is why not target each of these pathways? So the management involves targeting each of these pathways. Most of the data which comes is on animal studies, associations, observational studies, meta-analysis. There is no very good data available on if you intervene, what happens to sarcopenia. Does improvement in sarcopenia leads to better outcomes? It's been shown that sarcopenia has poor outcomes. Do you reverse it out? What happens? You take into factors like you reverse the liver disease with in terms of the MELD score improves, everything, the outcome improves, but then sarcopenia automatically, does it improve, or does the addition of incremental improvement in sarcopenia in a patient with a high MELD score, does it lead to any kind of outcome improvement? That is something which needs to be seen, and these are all drugs which have been used, like even the ammonia lowering agents would be used in these patients would have MHE or HE, and the other things, all these myostatin drugs which have been antagonists, which are still in the pipeline, animal studies. We still need more data in the humans. Coming to an important other molecule which has been not been talked about since yesterday's testosterone. We heard something about that, but then this is an interesting meta-analysis which shows you interesting results. They combined in 6 observational studies and 9 interventional studies on testosterone in patients with cirrhosis. Observational studies show you very clearly that in patients with cirrhosis, they have those who got low testosterone have sarcopenia, they have higher transplant requirement, they've got higher MELD scores and higher mortality. So this is seen in everything, when in every molecule which or every thing which you want to correlate, you'll show them to have poor outcome. Does then substituting it, do you give it artificially, does it leads to more improved outcome? The interventional studies show you very clearly, yes, you give testosterone level goes up, it doesn't lead to anything more than that. No improvement in liver related complications, death, readmission. So we still need more randomized controlled trials on this drug, but then also you need to think about is this has associated complications. You're increasing risks of HCCs, prostate cancers, other cancers, and portal vein thrombosis. So you need to also choose whether need to selectively and carefully do it in uncontrolled trials to see whether this molecule really works, and we need more data. In which group is the patient going to respond? Are you going to give it to females? You're going to give it to only males? That is many of those unanswered questions. So how to improve? You alone cannot do it. You need a team. You need a team of a lot of other people. You need is a cardiologist on board, endocrinologist on board, who are going to manage the comorbidities. You cannot manage them. Once you start managing, you're going to have lots of problems. You don't have time. So my suggestion or what I follow is like you need to have other people along with it. And this is something we have a dietitian, unfortunately, the physiotherapist and other people. So like as we're talking about what sir talked about, all those sports things, is that you need to tailor made exercise. You tell a cirrhotic start walking, a person who's on bed cannot walk. You tell him to do exercise, he cannot do. So eventually you're going to cause more injury to the patient by advising him a blanket kind of an exercise. So you need to sit, you need to have a trained person who's going to talk to a patient, do a tailor made exercise. Same with the diet is you need to have a dedicated dietitian with you as a part of the team. You need multiple other people, including counselors, is something very important. There should be a person whom the patient can talk to you. I'm sure we cannot give that much amount of time to patients. So patient needs their small little questions, queries, which they find it very, you may find it very trivial, but that's very important to your patient. And that's how, if you build up on that, you can think about improving outcomes, improving sarcopenia. Otherwise, it's really very difficult. So take home points: think, talk, and explain about sarcopenia to all cirrhotic patients. The patient may come to you at different stages, so you got primary, secondary, and tertiary things, but most important is start early. Pathogenesis is multifactorial. Target potential pathways where you got some amount of potential drugs available or other ways in which you can target it. It's a teamwork. Spend more time with the patient. That's important. And the most important thing is you need to have a big team, including dietitian, physical therapists, counselors, who should be an integral part of the management. Thank you.
Thank you, sir. Now we would like to invite Professor Amit Goyal, who is head of hepatology at SGPGI Lucknow. He is having keen interest in hepatitis B and C and has done more than 100 publications in national and international journals. He will speak on the topic exercise in patients with liver cirrhosis, do's and don'ts. Professor Amit Goyal.
Good afternoon. Good morning. Thank you, sir. I will like to thank Dr. Saraswat and Dr. Sunil for giving me this opportunity. I will briefly talk about exercise in patient with cirrhosis, do's and don't. So, exercise is advised in two contexts in patient with cirrhosis. One objective is weight reduction when cirrhosis is associated with obesity, or it is for sarcopenia. So I will not talk about the weight reduction related exercise, and I will restrict myself for sarcopenia. Sarcopenia means low muscle mass associated with reduction in strength or performance, and it is staged in pre-sarcopenia, sarcopenia, and severe sarcopenia. 1/3 of cirrhotic patients have sarcopenia. So in every slide, I am trying to give a message that every third patient with cirrhosis have sarcopenia, which is measured with CT scan, hand grip strength, and short physical performance battery. But it is not easy to assess every patient in our busy OPD, as Shalimar rightly told. Sarcopenia is managed in multiple aspects: nutritional supplementation, physical activity, ammonia lowering agent, and other things. And increased physical activity is one of the components, and that's why we are talking about the exercise in context of sarcopenia here. These are the 4 types of exercise: endurance, flexibility, balance, and strength. Each one of them are focusing and targeting different aspects in the performance and improvement. Basically, endurance exercise focuses on increasing the stamina, physical stamina, and the strength focuses on muscle mass improvement. I will just in this table try to summarize what is the difference between the 2 types of exercises. Endurance exercise lead to less lactate production because it is aerobic type of exercise, and more oxygen consumption. So muscle capillaries are increased. Splenic blood flow is reduced because more muscle is driven toward the muscles. So these are the positive effect of the endurance exercise. And because it is aerobic exercise, so it lead to increased number of mitochondria and the performance of the mitochondria. But muscle mass is not increased and muscle strength is not increased. So we can say that one type of exercise have some benefit effect and other exercise is having benefit in context of muscle and strength. And that is why we should recommend a combination of endurance exercise and strengthening exercise in cirrhosis patients. So this is a standard recommendation that how much exercise a healthy person should do. Sorry. There's some setting problem. Right. Okay. So more than 150 minutes of moderate aerobic activity per week, along with strengthening exercise 2 days or more per week. And that is the basis of recommendation of combining 2 types of exercise. This target is same for cirrhotic patient or patient with any other chronic diseases like arthritis or diabetes or any other things. Only thing is we have to try to achieve as much as safely possibly in a given patient. Patients with cirrhosis have impaired exercise capacity, and this is related to different factors. Sarcopenia is one of them, and we can say that at least a few factors such as sarcopenia is correctable to some extent. Effect of exercise. Now we'll come to some specific aspect of exercise in cirrhosis patient. When we do exercise, even in healthy population, it would lead to rise in serum ammonia, and this ammonia is produced by the catabolism of amino acid of the muscles. This is a very elegant study where healthy people and cirrhotic patients were followed during the exercise and seen that serum ammonia was elevated in both the groups, but the rise in serum ammonia was more in patients with cirrhosis. And we can see that the half-life of ammonia was prolonged in cirrhosis patient. That means the rise of ammonia was higher in cirrhosis and it was much more prolonged as compared to healthy population. But what is the clinical significance? We don't know as of now whether this sudden rise in ammonia is leading to precipitation of hepatic encephalopathy or leading to MHE. We don't know. This is the immediate effect of exercise on portal hypertension. When we do exercise, immediate means when we are doing exercise. At that time, it leads to rise in HVPG, reduction in hepatic blood flow, and increase in hepatic resistance. So these are the factors which lead to reduced blood flow to the liver. What is the clinical significance? We don't know as of now, because this is a temporary phenomenon. And the important point which I want to highlight, that the rise in HVPG is up to 21%, which is very significant. We must remember that 20% reduction in HVPG is our target with beta blocker. So whether with exercise, we are ameliorating all the benefits of beta blocker. So this rise is very significant. But when we continue the exercise for long time on daily basis, this is the study for which 14-week exercise was given, we can see that HVPG is reduced consistently. So whenever exercise is advised in a patient with cirrhosis, it should be continued. It may have some deleterious effect on immediate basis without clinical significance, but on long-term regular exercise, it is likely to reduce the HVPG. Effect of beta blocker. So shall we stop beta blocker when we are advising patient on exercise or not? Similarly, similar to previous study, double-blind placebo-controlled, very good study. In the placebo group, we can see with exercise, HVPG is increased, hepatic blood flow is reduced, and hepatic vascular resistance is increased. But this effect is not seen if the patient is on beta blocker. And we can clearly see that as compared to control, patient on beta blocker has drop in HVPG during exercise, but not rise in HVPG. So beta blocker prevents the exercise-related rise in HVPG. So coming to the main topic, what to do and not to do. As a disclaimer, there is no specific guideline to recommend how much exercise, which exercise to be done in patient with cirrhosis. And all the recommendations are giving general guidance about exercise. These data are basically extrapolation from the healthy population because data in cirrhotic population are very limited. So before advising exercise, first we have to screen for the safety of the patient, whether he can tolerate exercise, how much exercise he can tolerate, he is likely to develop any complication or not. Then baseline assessment of sarcopenia and fertility, followed by prescription of exercise plan, which is fit, which will be covered by the next speaker. I will not go in detail. So now summary of my entire talk, what to do. Everyone shall be advised for exercise because obviously exercise is good for everyone. Then why not those cirrhotic who don't have sarcopenia? Definitely those who have sarcopenia should be more persuaded for exercise, but it should be advised to everyone. Patient should be assessed for his safety before starting any exercise. Exercise should be gradually built up to avoid damage instead of any benefit. Prefer aerobic or endurance exercise over strength exercise because our objective is to increase the working capacity than muscle building. Combine all 4 types of exercise to optimize the benefit. Must couple your nutritional advice with exercise. Otherwise, we are likely to do more harm than any benefit. And ensure adequate dietary protein intake if patient is following exercise. What not to do? We shall not do heavy exercise at the start of exercise program, which is similar to any other healthy person should not start heavy exercise in one go. Exercise while alone at home because patient is likely to develop some complication like fall, hypoglycemia, palpitation, unconsciousness. So when he is alone, at that time he should not do exercise. Exercise during fasting period such as Ramzan period. If somebody is strict having cirrhosis and still having Ramzan or fasting, etc., then at that time he should be advised specifically to avoid exercise. Exercise during fasting state because it may lead to hypoglycemia. Exercise in presence of high risk varices, because as we have shown, in absence of beta blocker, HVPG is likely to rise up to 20% and may precipitate variceal bleeding. So we should take preventive measure, at least downgrade the varices or start primary prophylaxis, and then we should start exercise. And we should not stop the beta blocker because the positive beneficial effect already we have discussed. Exercise in the background of recurrent HE, MHE, portovenous shunt. This is the hypothesis. There is no data, as I have told, but because exercise increases the ammonia level, so it may worsen the condition. So we should consider this point. And if a patient is having any symptom which are enumerated here, they should stop or should not do exercise. So just in summary, exercise shall be advised to all the patients with cirrhosis. Evaluations are needed before exercise to prevent complication, and it should be gradually increased. Exercise prescription for every patient should be individualized, and protein intake must be coupled and optimized with exercise prescription. Thank you.
Thank you, Dr. Amit. Now we'd like to invite Dr. Madhumita. She is Associate Professor at Department of Hepatology, PGI Chandigarh. She has got a keen interest in cirrhotic cardiomyopathy, and she has got more than 50 publications in national and international journals. She is going to speak on the topic nutritional challenges after liver transplant and their management. Dr. Madhumita.
Thank you to the organizers for inviting me to this forum. I will be speaking about the nutritional challenges after liver transplantation, specifically the perioperative and the immediate post-operative phases. I have no relevant disclosures which are relevant to this forum. So we start off with the pre-transplant evaluation, which is what we've been talking about for the past 2 days, and how we look for sarcopenia, frailty, look at their nutritional assessment, and try to optimize the patient for what is going to be a major surgery, a major event in his life or her life, almost a marathon. The perioperative phase is equally important because ensuring good nutrition and perioperative care can actually translate into better outcomes. And of course, the post-operative phase, what kind of nutrition to be given, which has not been covered, so that can be covered with more detail. And of course, the nutritional rehabilitation and the long-term follow-up of these patients after transplant. So a liver transplant candidate is similar to all the patients that we have been discussing with decompensation, who have already had liver failure, ACLF. Those are the infections, especially the ones whom we are fast-tracking for transplantation, including complications like HRS, refractory ascites. So these are very difficult patients to manage nutritionally. And of course, we will do the assessment as suggested by all previous speakers for frailty, looking for malnutrition, for major and micronutrients as well. Bone hepatic osteodystrophy is an under-studied thing in this patient population, and bone health after transplant particularly suffers. So looking at sarcopenia has been covered in great detail, and specifically one needs to look for certain micronutrients like zinc deficiency, which impairs wound healing. It impairs the mucosal barrier. One needs to look at the degree of salt restriction, whether it is adequate or whether the patient is over-restricting salt. What is the kind of cognitive ability or the patient's understanding of the nutritional status of himself, and whether the family or the caregiver has been adequately counseled. So all these things need to be done. So it's not just the patient, but also the family and the caregivers, because the meals are prepared for the family together. We also need to be looking in terms of the specific dietary plan. So for every patient, depending on the cultural and the social context, one needs to give specific dietary advice, telling them what to be taking and what not to be taking, not just the standard prescription we write on the top, which is salt restricted, low fat, high calorie, high protein diet. It makes no sense. What is high protein in the cultural context? And then in terms of portosystemic shunting and hepatic encephalopathy and the ammonia metabolism, so looking at the protein prescription is really important in these subjects. So the nutritional assessment, we do the SGA or the Royal Free Hospital Nutritional Prioritizing Plan. And the stepwise one needs to look at what is the stage of liver disease, whether the patient has volume overload, looking at the ideal body weight rather than the actual body weight, correcting for the presence of ascites or edema, and determining the risk of malnutrition in such patients. One provides a nutritional recommendation in a critically ill patient. This would go up to 35 to 40. So 30 to 35 kilocalorie per body weight, and this is what we know. This is how we actually decide what is required for the patient. But what is actually to be understood in a patient who's being worked up for liver transplant, we need to be giving a specific exercise program which is tailored for every single patient, and minimize the number of fasting, because in the transplant workup we will be ending up doing a lot of investigations, and the patient needs to be told about the 4-hour 6-hour fast and nothing beyond that. So an additional snack needs to be advised on the day of the investigation, either early morning or immediately after the procedure, and no unnecessary fasting. For example, even now I realize people write NPO after endoscopy or after banding. So early, institution. And if we don't tell patients this is okay to eat after the procedure, they will not do it. So this needs to be specifically emphasized in the peri-transplant evaluation, and especially those who are critically ill. Do not delay procedures for these patients, especially when we are fast tracking them for transplant, or those who are critically ill. The nutritional status, once it is advised, needs to be looked at periodically. Should be at least annual in a patient with compensated cirrhosis, quarterly in decompensated, I would say monthly, to look at the exercise and dietary plan in patients who are on the transplant list. One needs to look at the micronutrients, B12, because that looks at that's a part of the the nerve myelin sheath, that is part of anemia. So anemia has not been discussed much, and it is an independent predictor of mortality. A low iron status is an independent predictor of cardiovascular health. Thiamine, when we look at wet beriberi or dry beriberi, and of course vitamin D. We're not yet clear as to whether vitamin D is going to actually help in changes in bone health, but certainly thiamine, the institution of it in critically ill, improves cardiac function. We know that giving iron corrects cardiovascular function in patients who have myocardial infarction. So by extrapolation, it's likely to also help in our population, though we don't have enough data. So in critically ill cirrhotics, the nutritional prescription must be revised daily. The floor consultant should actually be looking at the procedures that are advised for the day and decide whether the patient is getting or meeting those targets or goals. So in a critically ill patient, not only is the nutrition a problem, these patients are on ventilator, which is in itself a metabolic requirement. The patients are getting multiple infusions, including they might be getting dexmedetomidine or propofol, which are lipid-containing infusions. In all of these fluids, unless we're using syringe pumps, and in a peripheral hospital, they might be giving the prescription, you are writing the antibiotic, but the nurse might be giving it in 500 ml of normal saline. So writing the volume and writing the prescription correctly, the time and duration of infusion needs to be assessed. And of course, whether the Ryle's tube feed is being given properly, the gastric residual volume, one does not need to look at it every day, but whether prokinetics are needed, whether the patient is being given too much of lactulose, whether the phosphorus is actually dropping over time and the patient is developing refeeding, whether the magnesium levels are being controlled. So all these things need to be looked at in a patient who's in the perioperative evaluation. The Nutrix score is something that we follow. This also incorporates scores like Apache and SOFA, so you can see that this is not liver specific. And it looks at the, the comorbidities and the inflammatory state, and can identify the people who are at risk of being nutritionally poor in an ICU, and can also identify people who will require aggressive nutritional therapy. Now, in non-cirrhotic critically ill patients, this has been demonstrated to have an improvement in outcomes, but this has not been described in cirrhotic. So it's hard to say whether this will have any bearing in we can only extrapolate from existing data. How do we write the prescription in a patient who is on a transplant work list? Well, calculating the REE using various calculators based on the age, gender, height, and weight. And here it should actually be the ideal body weight and not the actual body weight as per the newer guidelines. So the dietary recommendations have been discussed, and we need to identify what is the requirement. Very briefly about direct and indirect calorimetry. So in the ICU, what we do have is a device that can be attached to the ventilator. It measures the vitiated carbon dioxide, and by means of an oxygen, it actually looks at the extraction of oxygen and the vitiation of CO2. And indirect calorimetry would actually be what can tell what is the metabolic requirement. So the ERAS protocol in the perioperative phase is enhanced recovery after surgery. Again, in the preoperative phase, once we have optimized the patient, prevented any decompensation or worsening or reduce the amount of fasting period, we actually calculate the energy requirement and decide whether the patient needs only enteral nutrition as in home-based feeds or additional supplements, which have been discussed. The role of BCA and specialized regimens is we are waiting for more data. It's probably going to be generated from India. And how this has to be given over standard diet needs to be looked at. And in the post-operative phase, looking at the energy requirement and the protein requirement, the recommendation is for early enteral nutrition. This holds true for any surgery, more so for liver transplantation, because we don't want any gut barrier or gut translocation to happen after surgery. So very early nutrition is started and gradually built up to the actual requirement or metabolic requirement of the patient. If you are not able to meet the need via enteral nutrition, parenteral nutrition as a supplement rather than total parenteral nutrition should be given. So we give something called profic feeds, where a small amount of feeds are given to maintain the mucosal barrier. So this is the practical guidance as far as the perioperative phase goes. So enhanced recovery starts with the preoperative phase when we first would admit the patient, the intraoperative phase to minimize amount of anesthesia, early weaning trials and early waking up and getting the patient off the vent, early mobilization from the bed, which means removing the urinary catheter. Something I find very curious, even in our hospital, is the patient's urinary catheter is not removed and they're not encouraged to move out. If they move, they will also move their bowels and there will be decreased requirement for anesthesia. Using of chewing gum, something as simple as that, just the masticatory action stimulates the gut movement. So gut movement is required. If the gut works, use it. Enteral nutrition is obviously going to be better than any parenteral supplement or any additional purchased prepared formula supplements. So using a good quality prepared meal or even blenderized meals would probably be better. And you don't require a soft diet. If the patient has teeth and he's cognitively aware and awake, let him chew. There's no need to give a soft, semi-digested meal to a patient who is active. So early enteral nutrition and proper nutrition. So this is the kind of diet plan that has been formulated in our PGS kitchen, and I realized when preparing this that we are not really focusing. So there's a dialysis feed, there's an ICU feed, but there's nothing which is specific to hepatic nutrition. And I think this is something that needs to be incorporated in all hospitals after discussion with our dietary departments. And we also need to incorporate the kind of calories that are going in from non-meals. So propofol and Dexmed, like these are lipid-containing solutions. If you are giving, a lot of DNS, all that needs to be calculated in what is being given. And very specifically, if we are not able to meet the challenges, if there's no gut, there's a gut motility, the patient's in shock, and we want to, the patient's on multiple vasopressor support, there'll be no there'll be no acquisition of nutrients from the gut. So in this case, one will have to give partial parenteral or total parenteral nutrition. We calculate the REE and determine what is the protein requirement based on the body weight. So 1.5 to 2 grams per kg, and divide the substrates between carbohydrate and fat. Now this could be different. Suppose we need to give very calorie dense meals, we could actually make this 50-50. So 60% from carbs, 40% from fat, but actually we might end up giving more of fats. In our ICU, we would end up giving more of ghee, that is salt free, not butter. So that actually helps in giving calorie dense meals. Also look at the kind of solution. So most of the time we have these prepared solutions which are partially lipid, partially having a protein supplement, and there's a place for giving additives. These are mixed together and it is given over 30 to 35 ml per hour continuously. So calculating the amount of lipid calories is also essential. And then one starts the parenteral nutrition, making sure that you look at micronutrients like magnesium, calcium, potassium as well, maintaining the electrolytes as well. So early ensurement of enteral nutrition starting at maybe 50% by day 1, day 2, and gradually going up to day 5, mobilizing and switching entirely to enteral meals, introducing exercise by maybe day 3 or so. And exercise meaning mobilization out of bed, removal of urinary catheter, removal of a PICC line, removal of central lines as fast as possible, ensuring that the patient is rehabilitated mentally and physically. So in a critically obese patient, Professor Sarai has done a wonderful job of reviewing the kind of data that is available. Very specifically for a critically ill, obese, cirrhotic, we will not be restricting any calories. These are patients who are on having organ failures, maybe having ventilatory support, organ support in terms of dialysis, and they need to be given the same amount or increased amount of calories without any restriction. And we are not targeting weight loss in an ICU. It happens in the post-ICU or discharge phase. So high protein goal is actually required, and a full, we need to be giving at least 80% of the ideal body weight caloric requirements, and maybe a higher positive nitrogen balance regardless of the ammonia. The reason, though we have picked up that ammonia would rise after protein, and we have detected this in our ICU, we found very little correlation with the grade of encephalopathy or the neurological status. So the gut, if it is not moving, we need to be ruling out GI infection, ulcerations, bleeding, paresis, bowel edema, and correcting secondary organ dysfunction. Very briefly, long-term after the ICU, sarcopenic obesity, new onset diabetes after transplantation, is something. Metabolic bone disease after transplant is something that every clinician needs to be looking at. So looking at the metabolic profile, insulin resistance, diabetes, and metabolic bone health is required. And the presence of frailty in one paper was found to be predictive of early rejection. So there is an immune mediated mechanism also, maybe by in the muscle metabolism, and immunosuppressant drugs. So certain drugs like tacrolimus and cyclosporine could affect the muscle, the myosteatosis, and of course steroids we know are associated with sarcopenia and frailty. So these are the conditions that will come up after transplantation, which have medical nutrition therapy as a basis for evaluation, and these need to be looked at and appropriate therapy and management actually instituted. So this is my summary slide, and this is a review that we have recently published in the Journal of Clinical and Experimental Hepatology. So this conference has covered the entire aspects of looking at a cirrhotic, depending on whether they are frail, sarcopenic, obese, the full profile, and to follow them up in the curative phase after transplant, covering their long-term follow-up is essential. So the journey is long, and we begin it accordingly. Thank you.
Thank you, Dr. Madhumita. Excellent session. Thank you all the speakers. Due to paucity of time, we'll skip the discussion and we'll end this session. Thank you so much.
Thank you, doctors, for airing the session. Now let's move forward with our next session of case discussion. To chair the session, I welcome our esteemed panelists, Dr. Mukesh Sarna sir, Professor in Department of General Medicine, Mahatma Gandhi Medical College and Hospital, Jaipur. Dr. Charu Dua ma'am, Head of Clinical Nutrition, Amrita Hospital, Faridabad. Dr. Surendra Singh sir, Assistant Professor in Department of Hepatology, SGPGI, Lucknow. And Dr. Karan Kumar sir, Professor, Department of Hepatology, Mahatma Gandhi Medical College and Hospital, Jaipur.
So while everyone's coming up to the dais, please come and get the session started. The program for the quiz. The quiz, I can see we have basically students from the dietetics stream here with us in the hall. So what we have decided is that instead of holding it the standard way, what we'll do is that the quiz with the options will be circulated to all the students who are in the hall, and Dr. Samiksha and Dr. Vinita Bansal will be coordinating this. 15 minutes will be given for the students to answer the quiz and return to the persons conducting it. And rest assured, there will be prizes announced to the winners of the quiz. So please take it seriously, and it's a very straightforward thing. You will not find it difficult. And I'd like to thank Professor Anup Saraya and Dr. Rajat Bhargav for their efforts in putting together this quiz. Thank you. Please. Over to the chairpersons.
So good afternoon, everyone. To begin the session, I would like to invite Dr. Rakhi Maiwal ma'am, who has been recently promoted to the post of professor at ILBS New Delhi. Ma'am has keen interest in the area of acute kidney injury in cirrhotic patient, critical ill cirrhotics, and ma'am has more than 250 publications in national and international journals to her credit. Ma'am, over to you.
Thank you, Karan. And thank you, Professor Saraswat, for giving me an opportunity, and Dr. Dadich for inviting me here. So, whatever discussions were left over in the previous session, maybe we'll have the discussion over here because all that is related to this case. And I'll just start on with the case. This was a 48 years old gentleman with a BMI of 32, and he was from Uttar Pradesh, and he was outside diagnosed with chronic liver disease, and his chief complaints while he presented to us in the outpatient was weakness and fatigue. He had comorbidities of suspected obstructive sleep apnea. Now, these were on the clinical examination. Like I said, he had no ascites, no pedal edema, he was non-icteric, so he had no clinical signs which were relevant as regards the decompensation was concerned. The investigations on this patient, we can see here, he had a well-preserved hemoglobin, leukocyte count was 5.9, platelets were reduced to 80,000, INR was 1.4, creatinine was mildly elevated, the GFR was 74, calculated by the MDRT4 equation, bilirubin was 1.15, AST was 84, and the AST-LT ratio we can see here almost 2. More than 2, and albumin was slightly low, 3.37. Alkaline phosphatase was 160. And the cystatin C we did for this patient because there was a mild impairment of the kidney function was high. The HOMA was 13.6 and FIB4 was 9, CRP was 7. And when you look at the components of the metabolic syndrome, he had hypertension, his arterial pressure was 96, his fasting blood sugar was 137, HbA1c was normal, his triglycerides were elevated, and so was the total cholesterol, and the LDL cholesterol was 101. Serum insulin fasting level was 40, and that's why the HOMA was very high for this patient. Now, urine analysis was not showing any evidence of albuminuria or proteinuria. Now, this was his initial ultrasound, which showed features of chronic liver disease with portal hypertension. There was no ascites. There was no suspicion of SOL. His chest X-ray was normal. As a protocol, we do the contrast enhanced CT scan for all these patients, and this also did not reveal any evident SOL in this patient. And there were features of chronic liver disease and portal hypertension. He had small, low-risk esophageal varices and mild portal hypertensive gastropathy. His 2D echo was normal. His sleep study he had done outside, and he was told to have obstructive sleep apnea, but he did not have those records with him. Outside, he was treated with carvedilol. He was given Pantocid, a PPI as usual, and a lactulose. And the working diagnosis for this patient, therefore, was he was a portal hypertensive patient, non-bleeder. He had small low-risk varices. His chronic liver disease was possibly due to NASH. He had components of metabolic syndrome and had morbid obesity class 1 based on WHO standards, but Asian standards class 3. He was he was diagnosed with hypertension recently. Suspected chronic kidney disease, again, maybe obesity related, also had obstructive sleep apnea. And this is how you see that most of these patients who have NASH related chronic liver disease or components of metabolic, you see that they will have multiple system involvement. Even though the liver is less involved here, the MEL score was 11 and he was CTP A6 because he had a low albumin level. So I would like to start here directly with the questions. So when such a patient comes to us, there is some suggestion on the initial investigation. He was also put, and many of us, we know that because he was complaining of weakness and fatigue, a detailed dietary history was taken and he was totally off fats. He was restricting his, he was on a sedentary lifestyle and he was restricting all his activities and was just purely on a diet, totally not prescribed by any dietitian, but from himself because he was told to just reduce weight and he was just focusing on that. So he had come to us with weakness and fatigue and these problems. So how do we start approaching these patients? And I would like, Charu, Dr. Charu to take over from here. And then we will discuss what usually we do in our patients, and then we can also have the people from the audience to contribute in that.
when a patient in our setup would come to us, so the clinician team has already done a baseline nutrition screening and assessment. Like they would have assessed for sarcopenia, they would have done their hand grips, and fertility would have been seen. So in our setup, when some special cases come to us, there is a handover kind of a thing. There is a telephonic consultation that a gastroenterologist is doing with the dietitian, which is a very ideal situation, because that gives you, that makes a multidisciplinary team approach a little more stronger. So when a baseline nutritional screening has been done, and it becomes easy for a nutritionist. So now in this case, what we should be doing is we should be assessing for fertility. We should also be assessing how the patient's hand grips are, and we should be doing a detailed assessment. There is no standardized gold standard nutrition assessment tool, but what we use in our hospital setup is a SGA assessment tool, liver related SGA tool. The royal hospital tools that we are talking about, they need a little more technicality, because muscle scores are also calculated, and not all nutritionists are trained on doing that. So what we will do is we will assess this, we will ask him take a 24-hour dietary recall in depth. And as already told by you, that he was off the fat content, right? So that is not the right way to approach, because if the patient is only eating a carbohydrate or a protein calories, and what calories is he eating? So you have to go into the depth of the calorie intake, and then start making your approaches, and understand what myths and what education level this patient has, whether this patient knows why it is important for him to lose weight, and is he a regular kind of a weight loss patient, or sarcopenia, obesity is also something that we need to take care in this patient, is what we'll have to understand, and then start our recommendations for this.
So thank you for that detailed comment on that. So how we do as clinicians in our setting is, whenever we have this history, so we rather go retrospect. So we look at the functional capacity of the patient first, and then to evaluate in detail. But the textbooks tells us that it is the first the muscle mass which goes, then your muscle strength, and then the functional capacity. So that makes us easy for us, because otherwise I'm not sure whether just picking up sarcopenia on a CT scan, and should we be intervening in that, and will it be helpful, and how will we be monitoring that, I'm not sure whether studies have looked into it. So that's how we do. We look for the functional capacity. What we do in our clinic is to look at the liver frailty index, which has a hand grip strength, so it looks at the muscle strength. And then you have the chair stand and the leg, the tandem leg testing. So that tells us, and the walk test, which tells us, the 6-minute walk test is also, which the gait of the patient by eyeballing itself tells us that the patient is functionally disabled or not. So you score the patient with that. And then we go on with either CT scans are usually done for cirrhotics, but not for non-cirrhotics. So again, we do not know, but DEXA scan is something which we do. Now, I'll also discuss few points related to CT scan and DEXA and the discrepancy that we see, and that we can discuss again. So we took a detailed history. So this patient was obviously obese, was put on and the frailty index, he was pre-frail. So he has a score of 4. And this was the CT scan of this patient, and you can see here that this is how you, this is a special software. So this is not done routinely for all patients, but if you want specifically, we can ask our nutritionist, and they give us all this detailed information. So you see here, this blue is the visceral fat, this is the subcutaneous fat, and this is a psoas muscle, which can be assessed to calculate the L3 vertebra level, which is used to calculate the skeletal muscle index. And this is what this patient had. So less than 50 is by the WHO standard. So this patient was meeting sarcopenia definition. But if you look at the Indian definition, Indian standards, he doesn't meet the definition. So that's again a discrepancy that we see. Now, if we calculate the visceral adipose tissue index and the subcutaneous adipose tissue index, so based on the literature, the cutoffs that have been proposed for males to say that there is high amount of visceral adiposity, it is 1.5 and above. So this patient had a score of 1.9. So he had more visceral obesity and also was sarcopenic. So very quickly, I'll just review. This was already shown by Professor Saraya, this slide, and this is the largest study of 600 plus cirrhotic patients, where they looked at the impact and they found that the prevalence of sarcopenia was 12% in this cohort. Myosteatosis, that is fat deposition in the muscle, may occur in the presence or absence of obvious obesity. So even patients who are lean, they may have myosteatosis, and it is also associated with worse outcomes. And sarcopenic obesity, a combination of both obesity and sarcopenia, is what becomes detrimental for these cirrhotics. So we've already heard about these definitions. So you need to have sarcopenia and you need to have adipose tissue, which is more. So obesity and sarcopenia together will qualify for the diagnosis. So you need to have an assessment of both these parameters to make a diagnosis of sarcopenic obesity. So in our patient, this patient had sarcopenic obesity, and because he also had complications, so this is a patient who has a complicated sarcopenic obesity, stage 2. Mechanisms have already been discussed, and this is how it is recommended again. So going back here, so we have to screen for initial functional assessment to say that the patient is sarcopenic, then go on to the assessment of detailed body composition analysis, DEXA scans, which can tell us and stage the patient based on the complication. This has already been discussed. So you have to take a very good history about the initial dietary habits, what the patient has been taken, because you need to understand whether this is really a loss of synthetic dysfunction or there is impairment due to nutritional compromise. And there are problems in obese cirrhotics when you're dealing with, to look at their mid-arm muscle circumference area, to look at the tricep skin fold may not be very reliable. And therefore what we need is, you look at the hand grip strength, and this is very easy with the handheld dynamometer. You can have it in your OPD. And these are the cutoffs which are proposed for males and females to tell us about the impairment. Now, this is the DEXA scan report just to show you that you have to calculate the lean mass based on the appendicular skeleton area. So this is the left arm, right arm lean mass, which is added to the left leg and right leg. And this is then divided by the height in meters square. Now, what I wanted to tell you over here is, when we see these patients, I have not seen the data, but when I screen patients for the muscle strength, many of these patients will be having frailty. Their DEXA scan will show us, because they have loss of appendicular skeleton. But still in these obese cirrhotics, many a times they do not meet the CT definition of sarcopenia, and especially with the Asian cutoffs. So this, I already showed you how we assess sarcopenia on the CT. We can see here, this is the healthy patient. So visual, even on the, even if you're not using these softwares, if you see the routine CT scan, you will be able to see the psoas muscle to say that the patient is, by visual eyeballing itself, you can find out whether your patient is sarcopenic over here. You can see here, this is a normal female, and this is the patient who is sarcopenic. So you can see that there is loss of psoas muscle over here. Now, when you look at the prevalence of sarcopenic obesity using the different cutoffs over here, so males, if you see this cutoff of less than 50, which has been proposed, it is 13.6%, and this is from our cohort, 2.4%. But when we apply the Indian or the Asian cutoffs, we find that the prevalence is very poor. So maybe these cutoffs, the way they have been derived, they again need to be re-looked into. These are few studies, again, they have been discussed. So I'll just, so sarcopenia, along sarcopenic obesity, and there is this myosteatosis, which is the lipid accumulation in the, or fat accumulation in the muscles. They both together become more detrimental in these patients. And I also told you about a combination of visceral adiposity to be assessed. So many a times there is more subcutaneous fat. The patient may be sarcopenic, but may not have more visceral obesity. So a combination of sarcopenia and visceral adiposity is further harmful. And again, if you compare three populations, patients were just obese, patients were just sarcopenic, but patients who are sarcopenic and obese, the patients who are sarcopenic and obese have worse outcomes. So before we go on to the case, maybe I will request Dr. Charu to take over her talk on life nutrition and, assessment, and then we can go back to the case. How would you like to run the session? Will you be taking any slides? Okay, you're not taking any presentation. Okay. So, yes, sir. Hmm. Okay. So, would you like to present?
Well, good afternoon, everybody. At the outset, I would like to thank Saraswat sir, Adich sir, Karan sir, and all the organizers for giving me this opportunity. So, coming to the exercise for prevention and management of frailty and sarcopenia in sarcopenic obesity. So, we know that exercise consists of activities that are planned and structured and that maintain or improve one or more of the components of physical fitness. So different types of exercise include endurance or aerobic exercises, strength or resistance exercises, exercises for balance as well as flexibility. So endurance or aerobic exercises include brisk walking, dancing, swimming, cycling, or any outdoor activity which can be done. Then coming to strength or resistance exercises, these include exercises for like lifting weights, arm curl, wall pushes, or using a resistance band to do these exercises and many more. Then comes exercises for balance, which could be yoga or tai chi or standing on one feet or doing the heel to toe walk. And then comes finally the flexibility exercises, which could be stretching, various kind of stretching exercises, including the inner thigh stretch, ankle stretch, and back of leg stretch. So now, what is the rationale of exercise therapy in patients with sarcopenia and obesity? Because we know that those patients who are sarcopenic and frail, they have increased risk of decompensation, increased risk of hospitalization, as well as poor outcomes post transplant also. Hence, we have to either halt or reverse the progression of frailty and sarcopenia in such patients to improve their outcomes. So coming to the impact of exercise on sarcopenia or sarcopenic obesity. So many studies have been done which have subjected patients with CTP A and B to exercise, and they have shown either they cause decrease in body fat mass or increase in muscle mass or both. But the catch is that these patients were not patients who were having sarcopenic obesity, although some of the studies contain patients with high BMI coming into the definition of obesity. So we don't have data of exercise on patient with sarcopenic obesity in cirrhosis per se. But when it comes to geriatric population, we do have studies that show that there is impact of exercise on sarcopenic obesity, and it causes decrease in body fat as well as increase in muscle strength as well as functions. So similarly, this latest meta-analysis published this year also showed that resistance training led to a significant body fat reduction as well as increase in muscle mass and increase in muscle strength as well as increase in gait speed, which are markers of frailty and sarcopenia. So now coming to the exercise training principles. So the first important exercise training principle is that we have to start with low intensity. Depending on the functionality of the patient, we have to progress slowly and we have to be alert for symptoms which have been beautifully explained by Amit Goel sir in the previous talk. So then comes the second important principle of exercise, which is the FIT principle, that is the frequency, intensity, time and type. So coming to the different exercises like aerobic, resistance, flexibility and balance. So the frequency, we have to start with low frequency. For aerobic exercises, we could start with 2 to 3 days per week, and gradually the aim is to increase to 4 days per week and to the maximum which we can go depending on the individual patient. Coming to the resistant exercises, we have to start with 2 or more days per week. And similarly for flexibility and balance exercises also, we can start with 2 days regimen per week. Now, when it comes to intensity, it can be judged by the box scale in which 5 to 6 or simply by knowing that whether patient is able to talk comfortably while doing exercise. So that much intensity amounts to moderate intensity and that much is enough. And when it comes to resistance exercises, we start with 3 sets of 10 to 15 repetition of whatever muscle group we are targeting, and then we can increase these sets as well as the number of muscle group which we are subjecting to exercise. And when it comes to flexibility and balance exercises, we can use stretch until feeling of tiredness or discomfort is seen in the patient. Now coming to the timing, again the timing has to be tailored as per the patient needs. If the patient is very much deconditioned, we can start with maybe 1 minute walk. He can take a rest, and gradually as his muscle builds up, his mitochondria as well as capillaries build up, we can increase it to, and the aim is to target 150 minutes per week exercise of aerobic training. When it comes to exercise for resistance or strength building, there are 7 major muscle groups which I'll be showing subsequently, and we can start with targeting one muscle group, and subsequently the aim is to increase to all 7 muscle group exercises per day, doing 3 sets of 10 to 15 repetitions. And when it comes to flexibility and balance, 5 to 10 minutes of 1 to 3 repetitions are sufficient. And type, I have already discussed what are the different types of exercises. So now this slide shows that the total energy expenditure out of 100%, 50 to 60% is the resting basal metabolic rate, which is kind of steady. We can't do much about it, and so do the thermal effects of meal. However, the exercise and non-exercise activity thermogenesis constitute 20 to 30% of the calorie expenditure. So this is the area where we need to target. So what is NEAT and why it is important? NEAT stands for non-exercise activity thermogenesis. It is important because without prescribing a patient to a particular exercise regimen, we can subsequently increase his calorie intake as well as his muscle conditioning, which includes walking your dog, pacing on the phone, cleansing the house, or dancing in the shower on the lighter note. So 1 hour of exercise is 4% of your day, whereas the non-activity exercise thermogenesis is almost more than 60%. So targeting this is much easier than prescribing outrightly exercise to a patient. So I think we can recommend definitely this entity to our patients. So these cartoons shows that home uh, home chores like carrying groceries, moving household, if done for subsequent amount of time, are equally good in burning calories as such resistance exercise like treadmill or squats or whatnot. So now coming to the programming levels, there are different. These are the recommendations. There are no clear-cut guidelines. So this has been adapted from a paper by Punita Tandon ma'am, which has clearly shown that for muscle strengthening exercise, there are 7 group of muscles: shoulder, biceps, triceps, quadriceps, lower leg, and multiple joint. So we can start with the introductory level, which includes very basic exercises, and as the patient's stamina and strength builds up, we can gradually progress to P1, P2, and P3. Similarly is the case for the flexibility as well as balance exercises. So this is the simple arm curl which can be done with weights as well as without weight. In the introductory part, we can do it without weights, and as the patient's strength builds up, we can increase the weight and do it. Then comes standing calf raises, which can help to increase the muscle strength of the calf muscles. So this can also be done in the introductory part, and as the patient muscle build up, we can gradually increase to more intensive training. This is the shoulder stretch, simple shoulder stretch all of us might have done. And this is the tricep stretch, which can be easily prescribed to most of the patients. So for more videos, I think I can recommend these websites for more detailed structured exercise programs. So now comes the important question: do we have any option for patients who are unable to perform exercise? Well, the answer is yes. There have been studies which have been done on whole body electromyostimulation. At least 2 studies are there from the geriatric population that have shown that patients who are unable to do exercise, and when subjected to electromyostimulation for 15 to 20 minutes twice per week for 10 to 12 weeks, they have shown that it has led to decrease in body fat as well as increase in muscle strength and mass. So it is not that we cannot do anything for patients those who cannot exercise, but only thing is the data on cirrhotic patients is lacking, and maybe we can do something about these entities. So to conclude, I would like to suggest this activity pyramid in which we should minimize our sedentary activities do strength training and flexibility training at least 2 to 3 days per week, and prescribe cardio or aerobic exercises at least 3 to 4 times, and can maximize the to daily basis. And then we can ask the patient to increase their non-exercise activity thermogenesis. I thank you all for your patient hearing, and I would like to apologize to my co-panelists and all the audiences, because I have a flight to catch, so I won't be able to participate in the discussion any further. So thank you for once again having me. Thank you.
Nicely set up. Okay, so I'll just go back to our case, because we've been hearing, and then what do we need for when the patient comes to us? So we have this patient here, and this patient also had, we did a TJLB for him. So he had NASH. The NASH score was 4, and he had F4 fibrosis. His liver pressure was 19 in a compensated cirrhotic, non-decompensated without ascites. The liver pressure was very high. And so now my next question would start from here to start managing this case. And we've heard all about the effects of exercise on the portal pressures, weight reduction on the portal pressures, and improving the sarcopenia. So how do we plan the nutrition for this patient? So what would you like to give him as the initial nutrition plan?
What we will have to do it, because the BMI is grade 3 obesity. So we will not be treating this patient as a regular weight loss patient, because we do not want the muscle to further lose. And we know that when you give very low calorie diets and you give blanket diets to these patients, you lose muscle more and you lose water more. So you don't want to do that with this patient, and this patient has already been doing that, the history that you gave. So we have to go very slow with these kind of a patient. First, we will calculate the calories, and the guideline says that you need to go to 20 to 25 calories per kg body weight, and you have to calculate it through ideal body weight. Right? Adjusted body weight in this case would not be applicable, because the patient is not decompensated. So once you have achieved the calories, that all right, this is the calories that you need to be giving to the patient according to the ideal body weight, you will go 500 to 800 calories minus, taking the recall of the patient, understanding the assessment of the calorie intake he is doing. So if he is eating somewhere around about 2000 calories, you cannot switch down to 1200 calories immediately. So you have to take the holistic picture into the mind. You have to make diet plans for this patient, which is moderate fat restriction. You will not go zero fat. You have to tell him that you have to sustain weight loss, and you have to give 5 to 10% weight loss in a month. We are not in a hurry. So 2 kg weight loss in a month would absolutely be good to begin with. And you have to use whole grains, you have to use healthy carbohydrates, and you have to make sure that in all his meals, proteins are given to him. So, and you have to encourage him to eat proteins. Even if you're giving him salads, I would want a protein insertion into the salad will help. Even if you're giving him a soup as a low calorie substitute, adding proteins would really help in these patients.
Okay, so further to that, I had few questions on the prescription which we are giving for the fats. What do you advise? What kind of fats they can take?
So in fats, we generally tell them to take a combination of oil. It is not that you will tell them to take only a one kind of oil, only olive oil is healthy. No, that's not the true story. You have to have a combination of omega-6 and omega-3, and omega-3 being the healthiest fats, and Indian fats, your mustard oil and soybean oil is rich in omega-3 fatty acids as compared to olive oil. So a combination of oil is what you will be giving. Even if the patient wants to have ghee, I'm absolutely okay that he can have ghee, but the amount, we have to cut down the total fat intake to maybe around about 20%. And in that, less than 10% from the total fat calories, less than 10% calories can be coming from saturated fats. But we should be avoiding trans fats in these patients. That is what we will be encouraging him, not to have street foods, not to have fried foods, not to have bakery food items. You can have dal mein oil, you can have roti pe a little bit of ghee. depending upon the calorie restrictions that we are doing. But there has to be a capping, objective evidence. Ek hi chammach of ghee, you cannot exceed more than that. Make your food palatable. Don't take very high fried and fatty foods is what we shall be recommending to these patients.
And what about supplementing with the protein, formula-based protein or branch chain amino acids in these patients?
So what I would suggest is supplementation of protein. Yes, you can give total proteins to this patient because that will be at the night time when you are generally what we follow in a weight loss scenario is you follow the circadian cycle. The highest calorie, like eat your breakfast like a king, lunch like a prince, and dinner like a beggar is what we follow. So when you are giving a very low calorie dinner, adding more proteins and if it is acceptable to the patient, because if a patient wants to eat food, you cannot say ki replace the food with the protein powder. No, you have to assess. But yes, giving a bedtime milk with a protein can be given, which can be a hepatic protein powders, but it has to be within your calorie limits. It should not go beyond your calorie limits. And so you have to balance between the non-protein calories also and protein calories, because if you over restrict the non-protein calories, then proteins would not do their work. So that is also very essential in such kind of patients. So giving hepatic protein, ONSs, etc. Unfortunately, low calorie ONS are very limitedly available, and the other protein powders like whey protein powders and a combination of casein and whey protein powder or isolates, they don't have branch chain amino acids. So selecting a protein powder becomes very challenging for a weight loss patient. But yes, you while calculating the calories, you can still give him, and your dietary branch chain amino acids is what you can focus on. Your dietary branch chain amino acids are also there. Need not supplement additional branch chain amino acids, because that's the studies are not very conclusive for branch chain amino acid in sarcopenia, obesity, that okay, additional as a therapy of a branch chain amino acid should be given.
And what about the kidney function over here? Would you like to pay that some
See,
attention?
now, as already rightly said by you, it still has to be evaluated. The creatinine is 1.10 and the patient is overweight. So you cannot say that this patient you have to give a low restrictive protein diet. Even the guidelines in the kidney disease patients and the microalbuminuria was also normal in this case. So you will not say that you have to reduce proteins. Even with stage 1 kidney disease, the guidelines are 1.8 to 1 grams of protein per kg body weight. So yes, it becomes very difficult when the kidney disease is advancing and the patients do not want to listen on the protein restriction. They want to listen mostly to the nephrologist, and they do not want to add proteins into the diet when a patient with renal disease comes to us. But in this case, we will not be, and this patient has not been diagnosed. So this patient would be easy to handle as compared to a already diagnosed renal case.
Okay, thank you. And Dr. Karan, what would you like to tell the exercise protocol for this patient? What advice would you like to give him?
So basically, this patient is having two problems. One is the obesity, and second is the sarcopenia. For sarcopenia, we have to give him protein, and second, we have to take care of the exercise. As described by Dr. Surender in his talk, we have to start with that fit protocol. We have to start. I will for this patient, I will go with the endurance exercise. Then we'll move gradually toward the strengthening exercise. And well, that is just for the patient has to start slowly, just build the exercise capacity, and then second step is the strengthening of the muscle by doing the increasing the weights and other things.
Okay. So resistance exercise, whatever way they should be made to do, because that will improve their muscle strength. And obviously aerobic exercise will cut down on the fat content and they will reduce weight. And that is more like if the patient can do a moderate
in this patient, you're specifically asked, this patient is sedentary, is not moving around.
He was told to be like the only myths, they start putting themselves on fruit juices after they are done. So that's the routine thing which we hear.
If he's
they
able
will be
to
restricting fluid, so that impact on kidney we wanted to reassess after He's not restricting his salt and fluid intake. So all that is started
Okay.
the moment they are diagnosed with cirrhosis.
So if it is able to do, I will definitely go for strengthening exercise. If it's not, then gradually from starting from endurance, then moving to strength.
Any other question from the audience which you would like to put up to the panelist? Or because we had detailed talks, so what here the goals will be to manage his.
So, Dr. Rakhi, I would also like to emphasize more on the quality of carbohydrate that we will be prescribing to these patients, right? So, the simple carbohydrates, the complex carbohydrate would take over the simple carbohydrate. Juices would not be the recommended choice when we are going on a weight loss journey. Even in cirrhosis
Juices
patients,
are rather harmful because the fructose is.
Yes, so that would not be the rather choice. And when it comes to even fruits, we would want fruits to be supplemented along with a protein supplement. So we do not want him to only fill himself with a carbohydrate content in the diet. And by design, Indian diets are rich in carbohydrates. So we have to choose the kind of carbohydrates is gonna be very, very good. And yes, International Millets Year. So including millets is something that we should be encouraging in these patients because rich in protein content. So one meal can be replaced with millets can also be one of the options given to these patients.
And many a times there is a discussion on the Mediterranean diet. So what?
Yesterday
your comments on the Mediterranean diet.
Yesterday I did include that in my session. So there is Mediterranean diet, there is DASH diet. We cannot cut, copy, paste. We have to follow in the Asian standard.
Asians
And that's what
cannot tolerate Mediterranean diet, so there's no point discussing Mediterranean diet for our set of patients. They will not take that diet. And yes, please.
I'm Dr. Sarna. I just want to ask you, Dr. Charu, when you have planned that you are dealing with a patient of sarcopenic obesity and you have planned a diet and exercise, how will you monitor and follow these patients? Because BMI is not a good indicator in these patients because BMI may remain same. You are losing muscle and gaining adipose tissue and BMI is same.
So see, monitoring the anthropometric measurements would all fail, specifically in sarcopenia obesity, because they would calculate the fat mass also. Hand grip is one way, and the visual impact. Like as a dietitian, what I train my team and train my dietitian, have a visual impact. Keep your eyes open. See how the patient is walking in your room. Is he on wheelchair? Is he able to walk without a support, etc.? So every time you give a diet, visual impact is the first thing. That is what is available currently with us. Yes, there are other things, but there is no gold standard presenting here. So visual impact is something that all the dietitians should also start looking in. So and then you have your diet diaries, you have your compliance things. To certain patients where we help, I tell them, okay, because you've prescribed, you just click a picture of what you're eating. Because in your mind, a katori size is X. In the patient mind, the katori size is Y. So when you want a high calorie, so you really want to see then also. And when you want a lower calories, then also it becomes more important. So sometimes I tell them, when you're coming for a next follow-up, usse ek din pehle ya 2 din pehle, just give your pictures of what you're eating, just put it on my WhatsApp. And when we are having our next follow-up, we pick it up from there and then we start the discussion, which leads into a effective monitoring and next evaluation. Yeah.
Okay, so I think so most points have been discussed. There is one more question which patients come and ask us is about intermittent fasting. So what would you recommend for a cirrhotic regarding intermittent?
I would not recommend intermittent fasting, not at
they
all.
They should be given rather late evening snack.
Absolutely.
And they should never fast.
Yes,
that's what
intermittent fasting, etc., keto diets, etc., all fat diets. No, a big no for
and
liver
even,
diseases.
Yes, please.
Fasting for a few hours is like fasting for days.
Yeah,
even the regular
so fasting for few hours is equivalent to fasting for 2 to 3 days.
And it is a very valid question because Indian females, it's very hard. sometimes Navratra work, sometimes Monday fast. So you
They
have to
feel
convince
fasting will
them.
help them reduce weight.
You have
So
to
that's
convince
not
them
the
that
strategy which they should be
you have to
following.
convince them not
Yeah.
to do the regular fastings also.
Yeah.
Hello. So a lot of our NASH patients have diabetes and diabetic kidney disease. So CKD stage 1, 2, 3, usually protein restriction is advised. So in that scenario, if the patient has diabetic kidney disease and sarcopenia, what would be the like protein recommendation and what would be the protein powder recommendation in such a situation?
So it's a very good question. When the early stages of kidney disease is there, and because there is sarcopenia, you have to encourage it. You will not reduce the protein content on these patients. Patients go hellbent on creatinine. You have to have a team approach. You have to have a nephrologist, gastroenterologist, and a dietitian standardizing the goals for these cases. But I have not read the guidelines for liver disease and renal disease in total. But when it comes to renal disease, stage 1, 2, 3, you have to give 0.8 to 1 gram of protein per kg body weight and then gradually reduce it. Right? So you have to take a multidisciplinary team approach. And when it comes to any kind of a formulation, you will pick up a renal formulation depending upon the electrolytes this patient is having. So if the potassiums are high, you will not be able to pick up any hepatic formulations. So if the electrolytes are normal, you can pick up a hepatic formulation. So you'll have to look into the phosphate content, you'll have to look into the potassium content, you have to look into the sodium content, and then you will decide on the formulation. Only electrolytes would be the key changers to pick up the formulation. If electrolytes are normal, hepatic formulas can be picked
up. I would say that assess the liver predominant or a kidney or both. So that will also make a, so if a patient has advanced decompensated and has an associated kidney impairment, so you should never curtail on the protein there.
I was talking only on the compensated.
Yeah. So renal specific formulas, compensated, yes, obviously then your goals will become different, but for decompensated, not at all. Okay, so can we conclude? Yes. Thank you.
Thank you, doctors, for enlightening us and airing the session. Now we are moving on to our next session, which is the debate. To chair this session, I welcome Dr. Vinay Kapoor sir, Senior Professor and Head in Hepatopancreatobiliary Surgery, Mahatma Gandhi Medical College and Hospital, Jaipur. Dr. Lokesh Jain sir, Consultant Gastroenterologist, EHCC, Jaipur. Dr. Neeraj Nagyaj, Consultant Gastroenterologist, Fortis Hospital, Jaipur. Please, sir.
Good morning. So our next session is debate on severe sarcopenia and frailty should disqualify a patient for liver transplant. The first speaker is Dr. Sanjeev Sehgal. He is Principal Director and Head of Liver Transplant and Biliary Sciences at Max Hospital, New Delhi. And he has more than 100 publications in various national and international journals. So I would request Dr. Sehgal to speak in favor of the topic.
Thank you, Lokesh. Thank you, chairpersons. Firstly, let me express my sincere thanks to Professor Saraswat and the entire team. I couldn't resist the invitation, and it was always a cherished desire to come here and see this beautiful place. This is a very interesting topic. I think we have been discussing about the nutritional aspects a lot, but this is what I would call as an extreme form of nutritional issue, which we are going to discuss now. It's like way beyond the clinical basics, and I mean, it might sound complicated for those who are not into transplant, for students in particular. So I'll try and give a very basic clinical judgment of the situation.
Now, I've been interestingly, the debate is between me and Dr. Kaushal Madan. So we work in the same place, we have traveled together, and we are staying in the same hotel. So honestly, we would probably know each other very well. So there is, you can say, got up game in this debate. So I really think that this is a topic which is extremely important. And the point to discuss today is severe sarcopenia and frailty should disqualify a patient for liver transplant. This topic itself is, you can say, self-explanatory, and I don't think that there would many, in fact, venture into a patient having a situation who's a very sick patient, severely sarcopenic and frail, and would embark on a liver transplant. So one may say that why debate at all? This is a straightforward thing. What is there in it to discuss? Because most centers would not like to take such a patient who's very sick. Now, there's a clinical correlation between sarcopenia, frailty, malnutrition, and performance status, which finally the patient expresses. This is what the students need to understand. What we clinically discuss, our scoring system and all, they reflect into a single theme, which is performance status. How well is my patient? Can he stand up? Can he walk from bed? Can he perform active daily living? So often people at our level who are clinicians, when we see a patient, we ignore these scores and we jump to what we call as an eyeball test. I'll go for my rounds and look at a patient and say, oh, this patient doesn't look fit for a surgery. You might say that it's a biased opinion. Well, it may be, but that's what I might feel at a given point of time. And this is called an eyeball test. So interestingly, it's important to understand that there has to be objective parameter to what I say. A feeling of a person or a doctor should not reflect into the overall treatment outcome of a patient if it is not supported by evidence of literature. And for this matter, it is important to have scoring systems, and it's important to actually then standardize what I treat in my hospital. The same is being expressed in a hospital, for example, MGM, or so, for example, in somewhere in UK or USA. So what I mean by severe frailty should not only be my opinion, it should be similar to other centers across the world. Now, just to give a start to this discussion, now this is like a patient who I was seeing 2-3 months back in our hospital in Max, a 56-year-old male who had a decompensated alcoholic liver disease, had ascites, was requiring recurrent large volume paracentesis, and was not responding to diuretics so well, what we call as diuretic refractory ascites, had a history of encephalopathy, and clinically, obviously, he would need a liver transplant because with advanced liver disease. He was admitted with recurrent chest infections, which improved to some extent. But look at it. He had a BMI of only 11.47, which is like the lowest of low BMI I've seen. Weight of 32 kilograms in a person who's 56 years old. And he had a poor performance status. Karnofsky is only 50. The liver frailty index was more than 4.5. So this is a patient who needs a liver transplant, no question about that. But he's extremely frail, severe frailty, what I would say. He had a very poor performance status. He could barely get up from bed and barely go to the washroom, actually needing assistance for that. So question is, what would you do for such a patient? Would you like to take him for a procedure which is as extensive as a liver transplant? Because that is also for sure that if you don't do transplant, he will not survive beyond a couple of months. That's for sure. He's really going to die. So there is a set of sick liver transplant candidates who are with you in your ICU all the time, who have either ACLF grade 3 or more, which is much more common these days, or who have advanced chronic liver disease with refractory ascites, spontaneous bacterioperitonitis, recurrent bleeding issues, alcoholics in particular, severely malnourished with sarcopenia, bedridden, are septic in one way or the other, maybe bacterial or fungal, and associated metabolic problems and multiple comorbidities. They may have cardiac, pulmonary issues, renal, and neurological, or so on. That makes their performance status even worse. Some of the scores which we see in frailty and all actually do not consider these other comorbidities, which also want to emphasize. We may say as a nutritionist that, well, this is a situation, this is the frailty score, this is the sarcopenic grading, but I may not have taken into consideration the patient's cardiac status, his pulmonary status, like somebody has ejection fraction of 35%, is frail, sarcopenic, versus somebody with ejection fraction of 55%, and he's similarly frail and sarcopenic. So my decision would change in selecting such a patient. So that is what I want to emphasize. What are we going to do? Our job as doctors is to do the best and make sure that whatever we offer to the treatment, it should really reflect as the best possible outcome. So sarcopenia, frailty, and performance status all in a way would impact my liver transplant outcome in a global way. And decision to choose a patient, whether to do a transplant or not, is actually as tortuous as this, puzzle. You can always be sure that the path you are choosing may not be the right one, and you may get lost of the way. So be very careful when you make a decision. Why severe sarcopenia matters? It is a triad of skeletal muscle mass, strength, and function. About 20 to 70% of patients with end-stage liver disease you have heard today are sarcopenic, and there are precise cutoffs for muscle mass and all. And in waiting list, it adversely affects the waiting list as well as post-transplant outcomes. So we are actually looking at this lower line, the severe sarcopenia patients where the muscle mass is very low, muscle strength is very poor, and they're very poor performance status. So to take these patients for liver transplant would really be, not the right thing to do. Many grading systems are there. I will not go into these, but we all probably understand today that what we are trying to focus today is a group which is not only sarcopenic, they are severely sarcopenic. That is what I want to address to, because many patients have sarcopenia which may not have so much of clinical relevance. And there are many factors which contribute to frailty and sarcopenia in these patients, both the pre-transplant, perioperative, and post-operative period. There's a dual interaction. If you are frail, you have these problems, and if you have these problems, you are more likely to be frail and sarcopenic. For example, post-transplant period, the critical care, critical illness, myopathy, the immunosuppressive drugs, corticosteroids, CNIs, the reduced physical activity, reduced nutrient intake, reduced nutrient absorption, systemic inflammation. Now, all these factors would contribute to the patient having a very bad situation and making them sarcopenic. So similar factors are there, the pre-transplant period, and of course, transplant itself is a very hypercatabolic state with an increased stress response. So now, in my next few slides, let me tell you how would I make my clinical judgment in a patient who's severely sarcopenic and frail. What I call it as an outcome assessment. So I have a situation in the wait list, and other thing is the post-transplant. So let's discuss them one by one, threadbare. Let's go to the wait list first. In the wait list period, there are many studies, elegant one. This is one of the studies from Alberta, Canada, by our colleague Purita, who has actually beautifully said that out of these patients, about 142, nearly 41 were sarcopenic. But what was important was that more sarcopenia was seen in those who were child C versus child A, which was about, which we all know about 50% of child C are sarcopenic compared to 10% in child C. And sarcopenia was an independent predictor of mortality. And clearly, those on the wait list who were badly sarcopenic had more waitlist mortality. There is a systematic review and meta-analysis, which similar data again. It says that if you have sarcopenia, the post-transplant and waiting list mortality is much more. And this is a US data. It again emphasizes the same thing, whether you have ascites as a decompensation, whether you have hepatic encephalopathy, and or you have sarcopenia. If you take all these three into consideration, what they want to emphasize is that in adjusted models is a frailty which remains significantly associated with waitlist mortality and not ascites or HE. So simply having a decomposition matters, but if you're frail and decomposition, that is the worst. Then once you decide to take, again I'm telling you what we are looking at a patient who's very sick, who's in ICU, who's having severe sarcopenia frailty. There it is very difficult to take them for transplant. And if you take, what is going to happen? Now these, in the immediate post-transplant period, we know that the patients may not do well, and we are aware that there are studies which say that elegantly that sarcopenia adversely impacts post-operative complications in living donor liver transplants, which really we are doing majority of the patients. And it says that if you have low muscle mass, there's an increased hospitalization cost. Now, this was the data from, again, US center, which, I mean, we can also have a similar experience in India also. I think we all are aware that, like, for example, in this study, they said that if patients who are sarcopenic, the cost was in euros about 11,000 euros versus those non-sarcopenic about 6,000 euros. This is, the cost difference, nearly twice the cost. I'm telling you, this is a very, very important problem. We might ignore it, but believe me, nowadays I'm very hesitant because I work in a private sector. We predominantly do living donor liver transplants because we don't get disease donors. And now people ask me, sir, kitna cost hai? What's the package? It's a really tough question now. The moment you take a patient who's very sick, severely sarcopenic and critical, and you decide to embark on a transplant, please be very clear, your cost may go exponentially high. The patient is going to need stay in ICU for long, may need tracheostomy, may need CRT, may need nutritional support, and he may spend the next 2-3 weeks in ICU. And the entire package goes topsy-turvy, and then you might find a huge bill, and the patients will say, well, you were doing a good thing for me. Why? We cannot afford this payment. And then the fight will happen. The bills are not cleared. These are the practical things. So now a doctor has to understand, why should I enter and jump into such a murky field? I know this patient may have a very poor outcome. Why do I do transplant for this guy? He's very sick. Well, my intention is to save. I agree that there's a strong possibility patient may improve. He may go back very well. But if things don't go well, not only the patients may have a bad outcome, may have morbidity, mortality, but understand, be very clear, that financial implication which we have may actually be so much bad for you that it will impact your next couple of cases in transplant. So please be aware of that. So that may also be one of the non-medical reasons for actually disqualifying a patient who's severely frail and sarcopenic. And if somebody has a better idea of how to overcome this financial crisis, I would be very happy and make my decision to transplant them much more easier. And then we also know that once you are having severe frailty and sarcopenia post-starts, it also impacts the long term. Now, long term, this is one of the studies which I actually worked across. One of my colleagues and he did the study, and we looked at the performance status. We actually would follow the Karnofsky, the KPS scoring system, and out of these 260 recipients who had living donor liver transplants over about 5 years, 3-4 years period, about we found that about 41 actually died at a median follow-up of 11 months. So when we looked at the survivor versus non-survivor, we were biased towards performance status. We wanted to know, does it matter? So what we found that if your Karnofsky's status was poor, then the outcome was bad. So 3 predictors in multivariate analysis came out as important predictors for mortality. One was poor performance status, one was post-operative infections, and third was recipient age. Higher age has a worse outcome. So if you have a combination of low performance status and patient is infected and elderly, this again would be a very bad case to take for transplant. So I would really be very careful in taking such a patient. This is again a similar sort of study. I'll skip this, but I'll probably mention this one, which I just published recently in JAMA Surgery, just 2023, from Jennifer Lai. She has really worked extremely hard from the US UCSF Center, and she's very passionate about publishing sarcopenia and its outcome on waitlist and post-transplant. So what she showed in this, cumulative data from 8 US liver transplant centers, out of the 358 liver transplant candidates, the global functional health at 1 year after transplant, the pre-transplant frailty was associated with post-transplant worse global functional health after 1 year. So even in long term, it says that your frailty does impact the outcome on longer term. That is what the message from the study is. And this is a very nice, a cartoon by this, by Duong et al. Published last year, which says interaction between malnutrition, frailty, and sarcopenia. You will see that frailty is in the center. If you're malnourished or if you're sarcopenic, you can be sarcopenic without being frail. That's clear. But yes, if you have both things together, you are frail, and then it impacts your post-transplant mortality. It impacts on your post-transplant liver transplant ICU stay, ventilatory need, and post-transplant infections. So basically, there's a negative impact of malnutrition, frailty, and sarcopenia on liver transplant outcomes, both immediate as well as long-term. So with this sort of a picture, what we are looking at, we might be having a very poor overall outcome if we embark on doing a transplant in somebody who's severely frail and sarcopenic. And what may end up, this is the next slide of my talk. this is one thing which I really want to emphasize: futile transplant. There's an entity called futility in transplant, which our colleagues from Gangaram, Ashish sitting here, we had a meeting, single theme, and we wanted to define what is futility. So, in my opinion, this is a group which may end up in a futile transplant. You may do everything, but nothing happens well. Patient may be, not having good outcome. There may be financial futility and so on. So, we don't want to enter into that stage. So, in summary, sarcopenia, frailty, they are common. It is a multifactorial comorbidity in cirrhotic patients, and these factors often coexist. And increased mortality and multiple complications on the wait list after transplantation. Also, there are a lot of problems if you are severely failed and sarcopenic, and there are a lot of health-related costs on the patients on wait list and liver transplantation. So, really, if you want to ask me, want to do it, well, let me tell you, in my center where I work, we are among the most adventurous team of hepatology and surgeons. Our surgeons are really adventurous. Kaushal is also probably good to speak on this, and we do take very sick patients at times for transplant. But in my very non-biased opinion, I'm very hesitant in taking such severely sick, frail patients who are on wait list and who are just in ICU, and it appears to me that they may not do well. So there is a right way and there is a wrong way. Now you have to choose what you want to do in your life. You have to make your life comfortable. Of course, right way is to do the right thing and make the patient come out with good successful outcome. So what I would say that, yes, in severe sarcopenia and severe frailty, one should not take a patient liver transplant. But if you are doing it on a very individual case-based selected, you can do. But in my personal opinion, one should really not jump into it. And I would say that yes, this patient should be disqualified. Thank you so much, and I would love to hear Kaushal speak on this further. Thanks a lot.
Thank you. Thank you very much. I think we'll wait for Dr. Kaushal also. So please come and join. So Dr. Kaushal is the Director and Head of Gastroenterology and Hepatology at Max, and he has a large number of publications. So he's going to say that sarcopenia and frailty should not be the basis for denying transplant. So we'll hear him, and then maybe we will have some rebuttal.
Right. So thank you, chairpersons, and thanks to Dr. Saraswat, Dr. Dadich, and Dr. Karan for inviting me to this pink city of Jaipur and this wonderful campus. So severe sarcopenia and frailty should not be a basis to deny liver transplant. And yes, if you see a case like a BMI of 11.3, which Dr. Sehgal presented just to make his case, then yes, I would also agree with him. 11.3 I have also not seen. And so you would also have not seen in your life a BMI of 11.3 in a pre-transplant setting trying to go for a transplant. So you may make any such cases, but in real life this does not happen. Second, I'll start from where he ended. He talked about futility of liver transplant. So INASL conducted a consensus meeting on futility of liver transplant, this very topic, in June last year. And it was considered futile if you were not able to give at least 50% 5-year of survival. So if any survival which is beyond that, beyond 50%, then the liver transplant is not considered futile. So let's look at the data. So the first question is sarcopenia really associated with low post-liver transplant survival? And he showed that data, and I concede, yes, it is associated with low post-transplant liver transplant, post-transplant survival. But the other question is sarcopenia associated with really low liver post-liver transplant survival? So low that you should preclude a transplant or not, or deny a transplant? The answer is no. So these are the studies. Look at this: 325 patients, adjusted 1 year post-liver transplant mortality based on dorsal muscle group area and total psoas area. The yellow bars and the blue bars are total psoas area and dorsal muscle group area. Smallest muscles to largest muscles. Smallest muscles, mortality was 24%. That means the long-term survival was 75%, much beyond the 50% threshold. Another study, 204 recipients of LDLT, since we do most LDLTs here, 47% sarcopenic, but in sarcopenia also the 5-year mortality or 5-year survival was upward of 70%, again above the 50% threshold. Two latest studies, again looking at the muscle area and post-transplant survival. In the sarcopenic group at 1 year in males, the survival was 75%. So even in sarcopenic groups, you are providing good post-transplant survival. So it does not deny these patients a transplant. Let's look at a study from India. This is from ILBS, 115 recipients, 47% were sarcopenic. But when they compared the impact of sarcopenia on mortality, sarcopenic versus no sarcopenic, 90-day mortality similar. So sarcopenia had no impact on post-transplant mortality. Second, you are basing your decision on the fact that you know what sarcopenia is. But the definition of sarcopenia is not standardized. You've been hearing this since yesterday. So is it muscle mass alone, or now the recent definition, whether you have to combine muscle mass with muscle strength to define sarcopenia? All studies which have shown low post-transplant survival have looked only at muscle mass and not combined muscle mass with muscle strength. Second, do you really know what the sarcopenia cutoffs are? People have been using a cutoff of 52 for males and 38 or 39 for females, which are Western derived cutoffs. Dr. Rakhi showed you a cutoff of 36 and 30. And this is what we derived, a cutoff of 27 and 24. So we really don't know what the cutoffs are. How can we depend on these studies which tell you these are the cutoffs, these are the sarcopenic patients, don't transplant, when we don't know the cutoffs? So these are the Western cutoffs. These are the cutoffs which we defined, published recently in ISG. And look what happens when you have a discrepancy in cutoffs. This, again, the Indian study. On one side, they say that muscle mass was independently associated with mortality. Muscle mass was. But when they defined sarcopenia according to cutoffs, sarcopenia was not independently associated with mortality. Only the muscle mass. So muscle mass is important, but your definition of sarcopenia is not. So you don't know actually which patients to deny transplant or allow them to go for transplant. Second, it is very difficult, if not impossible, to effectively treat sarcopenia in the pre-transplant period. It's very good. You had in the previous panel nutritionist sitting here, hepatologist talking about how to improve sarcopenia. You had Dr. Prem Kumar tell you how to improve sarcopenia in a decompensated cirrhosis. Let's see whether that happens. So the only treatment which has been shown to improve sarcopenia and therefore survival in these patients is TIPS. But are you ready to do TIPS only to improve sarcopenia? So this particular study, 173 patients underwent TIPS for portal hypertension. They looked at the TPMT, transverse right psoas muscle thickness versus height. In the post-TIPS period, 3 months, 6 months, there was a significant improvement in the muscle mass. And this improvement only persisted in those who had a patent TIPS. So you have to get a TIPS done to improve sarcopenia. How is it practical? Second, people talked about exercise, that it improves sarcopenia in cirrhotics. So this is a recent study, small study albeit, 40 patients RCT on a home-based exercise program versus standard therapy. No improvement before or after treatment and between the groups in the 6 minutes walk test, which suggests frailty. So, and they also looked at the mid-thigh muscle thickness, which also did not improve after the standardized exercises. And this was done in patients who had child's A cirrhosis. Imagine asking child C cirrhosis to undergo these kind of exercises and hoping the sarcopenia will improve. So that does not. But the best part is the most important treatment, it appears, for these sarcopenic patients is transplant. Their sarcopenia will also improve with transplant, and there is data. So again, small number of patients, 40 patients undergoing liver transplant. In the pre-transplant period, 55% patient had sarcopenia. In the post-transplant period, only 30% had sarcopenia. Their pre-transplant and post-transplant SMI in men and women, as you can see, there was an improvement. Although there was a trend, it did not improve significantly. Then people say that there are studies which suggest that in the post-transplant period, sarcopenia continues or new sarcopenia develops or sarcopenic obesity develops or myostatosis develops. That is fat inside the muscle which makes it even more worse. So look at this study. 161 recipients, 98 had post-transplant CT scans, 61% had sarcopenia in the post-transplant period, 25% developed a new sarcopenia, 73% also had it in the pre-transplant period. When they looked at independent factors associated with mortality, neither myostatosis nor new development of sarcopenia or presence or absence of sarcopenia in the post-op period had any impact on mortality. So it did not matter whether even in the post-op period whether patient was developing sarcopenia or myostatosis. Coming to frailty. You all heard that frailty is a clinical state of increased vulnerability to health stressors and it represents reduced physiological reserve. So when we were discussing about futility of transplant, this paper kept coming up. When is a critically ill cirrhotic patient too sick to transplant? So this was a consensus from the West. And the first thing they said was, if the patient is severely frail, that is a clinical frailty scale of more than 7, he doesn't go for transplant. That was their first thing in the algorithm. And they used this particular frailty score. So if they were moderately to severely frail, that is 6 or 7, that is completely dependent on others for activity of daily living and terminally ill. You all would have seen ACLF grade 3 patients. They are all bedridden. They have 2 or 3 organ failures and they are completely dependent on others for their daily routine activities. But do you deny them transplant? You are doing transplant every day in them, your own center. So again, showing you data of ACLF3. So this data shows that ACLF3, you are able to achieve a survival rate of 71 to 76%. And data from our center also shows that about 65% patients have long-term survival after ACLF3 transplant. Similar data from Western countries, 83.6% long-term survival even when you transplant in ACLF grade 3. If you don't, 90% of them die. And people have also talked about futility of care. People often quote this study and say that if there are more than 4 organ failures, then it is a futility of care. CLIP CACLF score more than 64, 100% mortality. But remember, they talk about futility of continuing care. It does not mean futility of transplant. If you go through this paper, it says futility of continuing the care in the ICU. If you have transplant, possibly some of these patients will survive. Coming to frailty. So frailty associated with mortality. A recent paper, again, you also quoted about LI. 1100 transplant patients, 21% patients were frail. Obviously, it was associated with increased mortality, increased length of stay, increased ICU stay. But look at the 5-year survival in the frail group, 84%. So would you deny such a patient transplant when you are able to give a life to 84% of patient? I don't think so. So these were the statements which we have put in the consensus meeting, which would come out soon in the form of a paper, that sarcopenia or frailty alone should not be considered as a futility for transplant in these patients. So to summarize, sarcopenia, even if severe, is not associated with really low survival, really low that you preclude a transplant. Even in studies showing low survival, the definition of sarcopenia is not clear. So even if he wins the debate today, you'll be going back thinking that those Western studies which did not know how to calculate sarcopenia are telling you to not do transplant in these patients. So please be aware. It is very difficult to treat sarcopenia, if not impossible, of patients who have ESLD in the pre-transplant period, and possibly the only treatment which can cure them of their sarcopenia and their disease appears to be liver transplant. Thank you for a patient hearing.
Very fascinating discussion. Dr. Rajiv sir, if some points you want to raise in the rebuttal or carry forward the discussion.
I could sit here. Well, I think this very interesting topic. I must thank Dr. Saraswat for bringing this topic for debate today. Now, see, actually, we are not comparing, apple with apples. We are comparing apple and oranges. What Kaushal is speaking, what I'm speaking, is not the same. Now, what you're telling is frailty and sarcopenia are not an issue. Well, there's no disagreement to that. I know it's not an issue. We are talking of severe frailty and severe sarcopenia. So we are talking about a group which is severely frail, severely sarcopenic, and I assume they're severely poor in performance status. So that is what we're comparing. That's number one. So what I am telling and what you're telling, probably we are not addressing the same group of patients. Number one. Number two, futility thing, I am an active part of that meeting which was done. Somehow I feel that in a living donor liver transplant, 50% is not a good figure to prove your case for transplant. Somebody donates for you, you do a transplant. I mean, you may argue that in a CA head of pancreas, you do Whipples and patients are not good to survive more than 3 or 4 years, 5 years at the most, and they all go for a surgery. But in an LDLT setting, I am not mentally very confident in accepting a 50% as a you can say a defining line for futility versus not futility. If somebody is very frail and sarcopenic, and I have to tell them, I almost never tell them that you'll have a 50% chance of survival, so go ahead with transplant. Until unless that I mentally feel that I can tell them that there's a chance of 80%, 90%, 70%. That's my feeling. I mean, I almost have never told my patient during counseling in the last 5,000-6,000 transplants that you will have a nearly 40-50 chance of survival, and let's go ahead with the surgery. I agree we sometimes do surgery which perhaps should not have been done because the outcome is very poor. There may be a lot of pressure from families, and well, it is a 50% for the overall, but for that individual patient, it is 100%. If he survives, he survives. That's it. And I'm telling you, many families, they are willing to take that risk. You tell them there's only 30-40% chance, they say fine, we are okay. And then it is very difficult to actually restrict your surgeons that no, you don't operate. So that is a problem which we face. I again say that we have to consider financial things when we take this discussion, because if you are dealing with a very sick patient, you really have to deal with very poor financial structure at some time, because who pays when the prolonged treatment is there? That's a big issue. So I think, and also the ACLF thing which we were telling, I am again not denying, we do ACLF3, we all know that it's a very sick patient. But the main CLD group, which is a bulk of transplant, which you do 70-80%, they are, if they're recurrently getting admitted, are sick, frail, sarcopenic, and again the severe group, there my level of comfort is very poor. If my patient cannot get up, I would leave aside ACLF and ALF. In a CLD patient, if my patient cannot get up from bed and go to the washroom, he is restricted to bed completely, I'm very hesitant in taking this for transplant. That would be my my rebuttal to the discussion.
No, I think, can I ask the chairpersons to actually have a vote of the House about, before we go ahead and open it to the floor for discussion, whether the answer to the debate is yes or no. No, they can participate. So they'll bias the audience, no? So they'll vote with the audience.
I think both speakers are trying to prove themselves. So I think we should individualize the patient, and every patient needs consideration.
No, just the outcome of the debate. What you recommend, what you practice are separate issues. There's a debate on a topic that's been held, and at the end of the debate, there needs to be a decision whether the yay or the nay, which side you people would say have carried the day. Yeah.
Audience poll can be there, yes.
So
how many are in favor of Dr. Sanjeev Sehgal, sir? Raise your hands.
No, I will not say that the debate is conclusive, but one point which Dr. Sehgal said, that the theme was severe sarcopenia. So let us not
Sarcopenia, as has been highlighted in the literature, is very frequent, but we were talking of severe sarcopenia, frailty, and poor performance status. The example you gave, that patient cannot even get up from the bed. So that is the subgroup that we are talking, number one. Number two, yes, ACLF we should exclude, because to some extent the poor performance status is because of the acute illness rather than the chronic. Yes, so that also we should exclude. Third point, which Dr. Kaushal made, that optimization of sarcopenia, frailty, or performance status, as he said, is very, very difficult, almost impossible. So that we have to accept. The issues are, as Sanjay also said, DDLT versus LDLT. In DDLT, it is the issue of allocation of organs, because there is, in every DDLT program, there is a paucity of organs. So in the allocation, a patient who is likely to have poorer outcome obviously will be a low priority. And in LDLT, it is, as he said, that the family, they come with the argument that we are giving the organ, we are going to bear the cost, we are willing to take this risk. So I kind of correlate that with, suppose a patient with metastatic lung metastasis, liver metastasis, CA head pancreas, says that, no, no, doctor, you please operate. Are we going to operate? No, we are not. So, and in LDLT, there is a lot of ethical issue involved, which the ethical burden is on the surgeon, is on the team. It is not on the family, the medical ethical burden. So there are issues involved. And you said cost, whether it is a package which your hospital is offering or whether it is an a la carte basis service you are offering, because then it is the family which has to decide. So I would say that this is one of many areas in medicine where we have to consider both the evidence and the wisdom which comes from experience. And as you said, that each patient probably has to be individualized, because other factors, the underlying disease, the age, the recipient age, the graft quality, the comorbidities, they also will have to be taken into account. So I don't think that we can, at the end of this debate, we can say whether severe sarcopenia, frailty, and poor performance status patients should be refused. But personally speaking, I would agree more with Sanjay that a patient who cannot even sit up or stand from the bed and go to the bathroom, you will be very, very hesitant to offer liver transplant.
I think if the chair allows, I think would like to say that I think this debate on sarcopenias and severe frailty, severe sarcopenia is probably a subset of a larger debate on what constitutes frailty or futility in liver transplant. DDLT things are a bit better identified, but in India we are mainly concerned with LDLT. So frailty is probably and sarcopenia are going to be major contributors to the decision of futility. Now, what the consensus on futility would be, whether the line should be drawn at 50, 60, 70% survival, is a matter that can be debated and a consensus arrived at by the LDLT specialists. But whenever you will, whatever threshold you draw, about 80, 75, 80% of the futility there would probably come from frailty and sarcopenia. Of course, there are other well-established conditions which you would probably not debate. I mean, we're more advanced conditions. So yes, eventually at the end of the day, it has to be an individualized decision, and the mere label of sarcopenia or frailty will not disqualify. The severity or the extent will be self-evident. If when you have a performance status of below 20, you don't even offer palliative treatment in cancer patients. So similarly, if the severe sarcopenia is such that the patient is bedbound, unable to care for self, then I guess they'll probably be disqualified from eligibility for liver transplant upfront. So I guess this is probably both the speakers as well as the chairpersons have probably articulated similar sentiments that this is a real debate. We do not have all the answers, and eventually it will all have to be individualized and slightly better objectified. Or when do you consider the entire effort futile?
Right. So on the same point, I think if you have to calculate a score to decide whether a patient needs to be disqualified or not, that should not be the criteria. Like you said, eyeballing is more important than. So if you have to calculate, say below this cutoff, I will not give transplant. I think that is a wrong practice.
One comment I would like to make here, that
the acceptance of liver transplantation in Indian patients is very poor. So once the patient comes and we tell them that you need transplant, most of the time they'll say, no, please treat me with medicine so that and then over the period, at that time the patient is relatively well preserved. But over the period, he accepts transplant when he actually becomes very frail and he is not able to do his day-to-day work. So we need to have some cutoff, and we can tell the patient in advance that if you cross this limit of frailty, then even the transplant would not work. So we need to have that cutoff because his acceptance comes once he's not able to do his day-to-day activities also. I think that's a very practical point which you have made, which at the time of counseling, we must take that into account.
Yeah, I think I must say this is actually a debatable topic. You know, many times we have topics in the meetings or conferences which are actually not debatable. This is actually a debatable, and I agree this needs to be individualized. My thoughts are, ideally, if you have to give a scientific evidence to something like this, you need to conduct a study, say 100 patients, severely sarcopenic, do transplant, and if all of them don't do well and you lose all of them, obviously you will say tomorrow you'll have that evidence to say that yes, severe sarcopenia is a contraindication and should not be done because everybody has died, right? But then it's unlikely that that kind of study would ever be done, right? So that's why we are debating and we are individualizing. That's one. The other thought is, there are so many indications or clinical situations within the liver diseases where you know that if you transplant this patient, the outcome probably is not good or may not be good, right? So what you do is you discuss that with the family. You tell them that even say ALF or grade 3 ACLF, but you need to tell the family that this is going to be the outcome. It's probably not going to be good. We can do it, but then there are more chances of losing the patient than gaining. But then that's what needs to be done and discuss it out. And I would feel that some of these patients, especially in the LDLT program, even severely sarcopenic, may agree that yes, we want to take this chance. Otherwise, also we are losing this patient. We want to take this chance, and they may even be transplanted, and there is a possibility that that patient may do well. So that chance has to be given, and that has to be discussed between the treating team and the patient family, and then a decision has to be taken. And as I said, this has to be obviously individualized. So one, I think what we understand, it is not a contraindication. Even I think we would agree. Severe sarcopenia, we don't have that much evidence to say that it is a contraindication. I don't think so. So whether they disqualify, I think these are my thoughts here.
Well, I must thank you, Kapoor sir, for your views and everybody's views here. One thing I just want to clarify. I told one of my residents day before, yeah, एक मुझे case दो, severe sarcopenia and frailty. This is actually a case, it's a real case, who was admitted with me, and lowest BMI I ever seen. I said, you're going to extreme. He said, sir, let's put up a case in the most severe way to impress the thing. So we do see patients, but again, I think it's not the number which is important. I think even if the BMI is 18, my patient cannot get up from bed, and he really cannot. This I used to see, I was in King's with Dr. John O'Grady, very bright, physician. He's the person who has graded ALF. And when I was there about 98, 99, so I used to see him, and he had a very interesting way of assessing a patient. He would go there, stand, and 2-3 minutes look into him, and just simply walk away. I said, "What did you do that?" So I made my own judgment. So that I think is very important, which is a matter of huge maturity, and that's what we can call eyeball test, which may sometimes be a biased thing. But yes, if a number is telling something, but my patient cannot, get up from bed, cannot, show the spirometry thing, cannot lift at least 2 out of 3 balls. No, he makes only 1 ball. I think then you really are in trouble when taking this patient. At the same time, but Ajay has a point. We have many patients to quote with who have been very sick and they have had a liver transplant, living donor, and they are actually in OPD now coming. So we have both the ways, and it's a hugely debatable topic. And again, my feeling is that this needs much more, debate and you can say discussion to arrive at a conclusion.
At least he has agreed to one. He started with his first slide saying there is no debate. At least he's agreed to that.
So this has been a wonderful debate. I think we can
That
go
was
on.
by regard to sir.
So we can go on discussing this thing throughout the day and without a confusion. But my submission is that if we take a decision to or against a situation in a situation, we will take a decision if we have something better to offer. This patient who is severely sarcopenic with decompensatory cirrhosis, is he going to make without transplantation? So that is my issue. We don't have anything better to option than if the family decides why should we go for transplantation?
Sorry, I did not get your last line. Yes. Well, that is what you just mentioned. The ethics of the transplant is the onus of the treating doctor, hepatologist, surgeon, and anesthetist. Family may want anything, but who is bearing that ethical, band in the hand? It's us. So we have to then actually be very careful if we jump into such a decision, especially in a living donor liver transplant, somebody is voting for you. So, well, I mean, family will put a lot of pressure, but till I see a figure which is much more respectable than less than 50%, I would still be very hesitant in taking.
The cutoff has been given as 50%, but if you look at all these studies, the survival has been upwards of 60 to 70% in most sarcopenia.
Thanks, Dr. Sehgal and Dr. Kaushal for nice debate, and thanks to audience for active participation. Thank you.
Thank you, doctors, for this wonderful debate and airing the session. We now invite Saraswat sir, Karan sir, and Vinita ma'am for valediction.
Well, good afternoon and everyone, and I think we come now to the end of our 1.5 days meeting, and I think I'll invite all the members of the organizing committee who are in the hall to please come up. Professor Dadich, Dr. Rajat, Sudhir, and is Dr. Akash here also? Vinita ji and Karan. So, and is Dr. Anand Jain here? Anand, please come up. So these are the people who have been instrumental in working hard and making this 1.5 days meeting work, and for us to listen to all this scientific component. Abhinav, tum kahan reh gaye bhai? I said all. Sorry, my fault. I didn't. Yes, Abhinav. So I think the first thing on the agenda would be that we had a poster competition in which posters were judged by one of by Dr. Shastri, I think. Dr. Shastri and Dr. Karan helped them. And I think I'll request Karan to come up to the dais and tell us about the poster session to the podium and who have won the prizes. And if they are in the hall, they can come and take their prizes. So, Dr. Karan, come here.
So good afternoon, everyone. So yesterday we held a poster session in which all the poster dedicated to hepatology. It was not dedicated only to nutrition. On the hepatology, all the perspective were there. So first prize among the poster goes to Dr. Saksham Seth. He is a resident at SMS Medical College. He has presented data on a randomized controlled trial which they are conducting at this center on sarcopenia in cirrhotic patient and effect of dietary intervention in improvement of sarcopenia. He has shown some encouraging result in that. I think Dr. Saksham is not here, so we'll request Dr. Sudhir to take prize on his behalf. Happy Diwali, sir. For second prize, there was poster by Dr. Urvashi Gupta, who is a senior resident in Department of Medical Gastro at Mahatma Gandhi. She has presented a case series in which she had shown patient with gastric variceal bleed who were successfully managed with BRTO in emergency conditions at a primary, the failure to control bleed with the endoscopy and BRTO as a rescue and all the successful interventions. May I invite Dr. Urushi, please? For quiz competition, I would like to invite Dr. Vinita to announce the winners.
Thank you, sir. So now we have results of our quiz competition also. I would like to thank and congratulate all the students as participation matters a lot. And now I will announce the names of all the top three winners of the quiz competition. First of all, I would like to invite Miss Akshaya Singh. Akshaya Jain, sorry. She is BSc Nutrition student from Jaipur National University. Actually, top three prize has been given to top three people, and two were first and one was second.
Tie for the first.
There was tie for the first position. Next, I would like to invite Miss Sarita Mirdha. She is sharing also first prize. Next, I would like to announce the name of our third participant, third winner of the quiz competition, Mr. Ritik Agrawal. He is BSc second year student of our Mahatma Gandhi University of Medical Sciences and Technology.
Well done.
Sir, I would like to mention that he has not studied therapeutic nutrition till now. Still, yeah. Thank you so much.
Well, I think that basically brings us to the end of our program. We didn't. The quiz was already conducted while the rest of the sessions were going on, and valedictory means saying bye bye to everyone. I think only a handful of faculty people are left here. Everybody has the compulsions of their flight schedules and travel plans, so everybody else is left. And I think I'm only left with the pleasant duty to thank all my co-members of the team who have worked so hard for the last several weeks. We really got into the act of preparing for this about a month ago, and all the effort that was put in. And I'd also like to take this opportunity to thank all the speakers who worked very hard. I think the attendance may not have been what we have been expecting and seeing at national meetings and at others meetings. But what I can say is that the quality of presentations and the talks that were delivered here was outstanding and at par with what is the best we have seen in our national meetings and even in some of the international fora. So for that, I think it is a tribute to the depth and the quality of Indian hepatology that we have had such outstanding talks. So now with this, I'd ask my team members anything else. Sunil, can you please come up and say a few more things, because I'm not sure I'm covering everything.
You have covered everything except to thanks to INSL people, INSL Governing Council, for allowing us to conduct this meeting, this single theme meeting, permitting us to do that. And that's a big thing. Thank you very much, INSL.
Anybody else among the organizing team, one or the other? Right, then I think we call it as the end of our meeting and invite everyone for lunch.
I think before you leave the hall, I think we must thank our big energy source, Dr. Saraswat. I think he's been, keeping us all on our toes. And Dr. Ajay, please come. So I think a big thank to Dr. Saraswat for making this thing happen at this place. Thank you very much.
Yes.
Please come.